So I had it like on whatever, but I had it, but nobody else had it.
So
It won't let me
we
share.
gotta call Eric and allow you to share.
Oh my God. All right.
Do I need to say something to Eric, or you're talking to Eric? Eric, can you allow me to share?
All right, Robert. We'll be in touch. All right, thank you. Yes, it still says no network address on the top left of the touch panel, so we're just gonna continue what we got planned. All right, thank you.
Can you just make sure my volume is up for everybody? All right, I'll let you do it.
Okay.
I'm gonna let him do it because he's
All right.
okay. We're getting,
All right.
but just make sure my
Your volume is all the way up.
do you know what I'm saying?
Yes.
I think they won't see us.
They won't see.
You can have people that's up there. All right.
Okay.
All right. All right, let's go. Joe, okay, we are going to get started. So, you gotta talk to the microphone. I'm sorry. Well, Sam, you're going to start. So we're about to get started. So I'm going to introduce Sam Guild, who's the president of AIM at Melanoma, the preeminent melanoma patient advocacy group in the country, if not the world. So Sam, I will let you start the introduction. I will continue our introduction of our Stanford program, and then we'll get this symposium going. Welcome to everybody live streaming and on other media venues watching us. Thank you.
So thank you everyone for joining us, and thank you, Susan. So if you're joining us via live stream, thank you for joining us, and hello. You're going to have to bear with us a little bit. Yes, we're in Silicon Valley, but yet we are having tech issues, so we're going to make the best of it. I want to thank, of course, Stanford Healthcare for co-hosting this event with us, Dr. Susan Swetter, Dr. Allison Bediff-Warner, who are the co-moderators this morning, our panelists, Linda Plout, who is helping, who's our symposium coordinator, Angars Taylor, who's from AIM, who's also helping to coordinate this event, the Stanford volunteers, Christina, Lisa, and Laura, and of course, all of you who have joined us today, again, via live stream or in person. We are so grateful for your support and for doing more to help educate yourselves and others about this disease. I'm going to go through a couple more logistics with you. I will introduce the foundation to you later. I want to mention the questions. There will be a Q&A later on, so please hold on to those questions. If you're joining us in person, there is paper in the folder along with the agenda and a survey, which we strongly encourage you to complete after the event. For those joining online, please put your questions into the comments. We will include those into the Q&A. So if you're on Zoom, put into the Q&A, social media, the comments, and we will try to get to as many questions as possible. If we are unsuccessful, AIM at Melanoma does have an Ask an Expert, and we'll encourage you to reach out to them. Or of course, we always encourage people to reach out to your healthcare provider. So without any further delay, so I almost said Dr. Swetter, but I'm like, Susan, go.
Thank you, Sam. So for those of you who don't know me, I'm Susan Swetter, and I've been at the helm of the Stanford Melanoma program for 30 years, which just seems unbelievable. But 15 years ago, we had Dr. Sunil Reddy join us on the medical oncology front. About the same time, we had Dr. John Sun Wu as our head and neck surgeon. John couldn't be here today. And over the last several years, we've had a wealth of new expert faculty joining the Stanford Melanoma program, including Dr. Amanda Karani, who's come from University of California, Davis. And Amanda is heading our surgical oncology program within the cutaneous oncology program, treating melanoma and other skin cancers. Dr. Allison Bediff-Warner, who joined us a year and a half ago from Sloan Kettering. And Allison is amazing. She is co-leading the melanoma program with me, but directing our clinical trials, cell therapy program for solid tumors, and the TIL therapy program, which she'll talk about. And finally, Dr. Pauline Fonchain, who joined us a year ago from Cleveland Clinic. And Pauline is treating the spectrum of melanoma cases along with our other medical oncologists, but also treating a lot of the advanced non-melanoma skin cancers, co-directing immunotoxicity, which is a big problem we see with the immune checkpoint inhibitors, as well as cancer genetics. And so I'm so happy to have my colleagues here, along with my dermatology friends and colleagues, Dr. Albert Chu and Don Siegel, and soon already will participate in the panel. So we are very excited with what's happened in the melanoma field, and particularly I look back to 30 years ago, and even 20 years ago, there wasn't much going on in the way of offering patients effective therapies. We had a little hope with interleukin-2. We had interferon in the high dose, which was just an abominable therapy for patients with lymph node disease. We had radiation therapy, which we seldom use now for lymph node or other adjuvant therapies. And so we've really seen these remarkable changes in patient survival over the last 10 years related to new immunotherapies and targeted therapies. And we will focus on advanced melanoma today, along with talking about what's happened in turn with early detection and prevention, novel technologies, artificial intelligence, augmented reality, things that we can do to really push the bar to pick the disease up early. Okay, so our agenda today, I'm going to talk about our Wipeout Melanoma California community engagement efforts. Dr. Chu, oh, sorry, we're holding on. That gives me time to put my glasses on. Okay, are we back on normal?
Yeah, I'm looking for the PowerPoint.
This deck, that's the deck.
That's the
Right
one.
yeah. So following my talk, Dr. Chu is going to talk about realities of AI for melanoma detection. Don Siegel, pediatric dermatologist at Stanford, is going to talk about the augmented and virtual reality ways that we're trying to improve education about primary prevention. Can we make this bigger? And then we'll have Pauline Funsheen talk about the role of genetics in melanoma. Dr. Karani is going to talk about adjuvant surgery in melanoma, including new approaches to upfront therapy. Dr. Bedoff is going to talk about TIL therapy, tumor-infiltrating lymphocytes for advanced melanoma. Sam Gill is going to give more information on AIM at melanoma patient resources. We're very pleased to have Alex Shushari join us from Sloan Kettering, and he's going to talk about some of the melanomas that are not related to sun exposure, acromelanomas on the palms and soles, mucosal melanomas we see in the sinonasal area and genital region, along with uveal melanomas in the eye. And then we're going to have a panel discussion for Q&A and also focused on some of the advanced therapies, and Sunil will participate in that along with the group. So again, welcome. All right, are we all set for the moment here? Okay, so we're still working on a few IT things for folks that are online.
New share.
It's a new share, okay.
Oh, this is the one.
I think, are we back online now? Are we back on the normal? Okay, all right. So welcome again, everybody. We're delighted to co-host this symposium with AIM at Melanoma. And I'm going to talk about what's happening in the field, if I can advance the slides. Okay. Let's see. Linda, can you pop up? They're not moving on the advance here.
You click this.
That, but not this. Okay, so you have to do this way. Okay. Okay, so just to get us going, I'm going to talk about a little bit of melanoma incidence, the number of new cases we see per year, as well as mortality, the deaths that we see. So there will be over 100,000 cases of invasive melanoma this year in the United States. Most of those are occurring in white individuals, though we are seeing an increased burden of disease in people of color who tend to present with more advanced tumors. Melanoma right now is the 5th most common cancer in both men and women in the United States. It is not, though, a leading cause of cancer death when we compare it to breast, colorectal, prostate cancer, et cetera. That being said, we've seen, as a melanoma team, we see many, many patients who succumb to melanoma. In fact, it's estimated that about 2 individuals in the United States die per hour, including melanoma and other types of skin cancer. So there's a lot of work for us to do. And as I mentioned earlier, it's only been in the last decade that we've seen the mortality rates, the death rates from melanoma begin to decline due to better therapies, immunotherapies, and advanced disease. Okay. Sorry, this is just not, it's intuitive. Okay. That's not moving, sorry. Is there a way to do it here? Okay. Oh, all right. Okay, so it's this one? All right, we're getting here. Sorry, folks. All right. So when we talk about precision medicine, we're talking about sick care. We're talking about therapy that we give to treat active disease. When we talk about precision health, though, we're actually talking about disease prevention. And this can include a number of facets. So prevention, we think about reducing harmful exposure to the sun for melanoma and other skin cancers. But we also want to think about legislation, and AIM at Melanoma was really critical in trying to reduce tanning bed use by minors in 21 states, and in fact prohibiting it. And we want to get to that point where we ban tanning beds entirely, like has been done in Australia and other countries. When we talk about early detection strategies, we're not talking now just about telling patients and providers to look at the skin, but we want to empower consumers. We want to put tools in their hands so that they can look at their skin, know what clinical warning signs are, perhaps use a smartphone app with validated AI to help triage into the right specialists, use telederm to get into care early, and detect that melanoma as thin and early as possible so that we can effect cure. Sorry, these slides are still not advancing. Okay. When we talk about primary prevention in general, it's estimated that if we were to enact sun exposure behaviors before the age of 18, we could prevent about 80% of non-melanoma skin cancers, at least in people as they get older, which would be huge because we see over 6.1 million cases of basal cell and squamous cell carcinomas per year in the United States. And a lot of people get that sun damage early in life. So what Don Siegel is doing to try to enact primary prevention campaigns in the adolescent years is critical. We know from a large Australian study that melanoma can be prevented by using regular sunscreen and other sun protective measures. But in reality, we have real challenges related to our US sunscreens and protection from the sun. So just to give you a real brief primer on the radiation from the sun, ultraviolet light accounts for only about 6% of the sun's energy reaching the Earth's surface, with the vast majority being visible light or infrared light, which have much longer wavelengths and really can't be prevented much in the way of sunscreens. Just protective clothing would be helpful. In terms of harmful ultraviolet light, again, which is relatively low percentage of the sun's energy reaching the Earth's surface, the UVB and the UVA rays are the critical ones that cause skin cancer and other photo damage, photo allergic reactions, and so on, cataract formation and such. And we're looking at UVB light and UVA light that extend from 280 to 400 nanometers. One of the difficulties we face in the United States, though, is the efficacy of sunscreens. And this has been a long-term frustration for many of us in the melanoma prevention and control field. And in reality, there are many better filters available around the world that go to that far UVA spectrum, 400 nanometers, and do a much better job in preventing harmful UV radiation and ultimately skin cancer. I've put this list of slides or ingredients so that you can recognize them when you hopefully purchase these from abroad, which is what I always recommend my patients do. And they have trademarked ingredients called Tynazorb, Tynazorb S and Tynazorb M, Mexeril, there's varieties of that, Uvanol, varieties of that. And now there's even a new one called Triazorb, which is out of Europe. These are all Europe and Asian markets and such. These are sunscreens that are actually going to go into that early visible light spectrum for the first time. And that's important as we see a lot of pigmentary change occurring in that blue light spectrum that's between 400 and 400 nanometers. In the US, the only effective sunscreen we have chemically is the avobenzone. It goes to 370 nanometers, so it's not reaching far UVA light. It is photolabile, meaning it breaks down in the sun. Go figure, we don't want a sunscreen that breaks down in the sun. And it really isn't as effective. And so mineral sunscreens themselves, which reflect and deflect light, are also not really hitting that. So it is, we believed, and we very much hope after a 22-year effort to get these superior filters into our sunscreens, that at least the Tynazorb, bumetrizenol, which is the bedrock of European and Asian sunscreens, will be in the US market by the end of 2025. So fingers crossed. I'm going to pivot now, though, to survival by melanoma thickness. So when we look at melanoma as a cancer, it's considered the most deadly because it's only a minute fraction of tumor difference that makes a huge difference in survival. We see a patient with a hairbreadth thick melanoma, that's about a millimeter, surviving at about 98% at 10 years. We add 3 more millimeters to that, a 4 millimeter tumor or greater, a T4 melanoma, we'll call that. Survival drops to 75%. So there's a strong rationale to detect these tumors when they're flat. they haven't metastasized to the lymph nodes in the bloodstream, and they're more curable. The problem is, of course, we've got a visible cancer. Why can't we pick this up when it's, again, a thin tumor? And we've done work at Stanford to actually look at what's happening with thickness-specific incidence trends. This is using the large National Cancer Institute data, the SEER cancer database over 8 years, over 180,000 patients. And we looked at thicknesses of melanoma according to age, patient sex. We looked at socioeconomic status as well as race and ethnicity. And what we see is that the thickest tumors, those T4 tumors, are continuing to rise at about 3% per year in the United States. And the burden of that is particularly borne by people of color. So we're seeing this in Black and Hispanic individuals, along with individuals of low socioeconomic status. So there's a real rationale to try to reduce these more lethal, deadly melanomas and target the populations in whom we see those elevations continue. We need to better target our communications about melanoma. We know it's rarer in racial and ethnic minorities, but they're 2 to 3 more times likely to die from disease than non-Hispanic white patients. We still direct much of our messaging regarding early detection and prevention to higher SES white individuals, and we need to refocus some of the messaging to include people of color, understanding that they're at risk for melanoma, though the risk is lower, but understanding what it looks like when it occurs so that we can detect disease earlier rather than later. And this is a picture on the left of the 4 melanoma slides I have over a 30-year career that are the thinnest, flattest, and you can see they're not that flat, thinnest melanomas I see in people of color. We call this Fitzpatrick skin types 4 through 6. Most of the tumors we see in people of color occur on the acral areas, which Alex is going to talk about a little bit later. And this is the palms, the soles, fingernails, and toenails. And most of the time, these are unrecognized. It's treated as a fungal infection. Someone stepped on a nail. They have a bruise on the foot. So we really need to, again, improve that awareness as opposed to the typical messaging you see on the right, which is very busy, related to the ABCDs of melanoma and people with lighter skin or moles, which is still relevant, but we need to kind of share this messaging for acromelanoma. In California, we started the Wipe Out Melanoma California statewide initiative, and we launched this 4 years ago at the height of the COVID or the beginning of the COVID pandemic. But our goal is to really target these highest risk groups in the state of California to combat lethal melanoma, the thicker tumors that we see continue to rise. We want to lead the way in prevention, community outreach, and novel diagnostics. We've developed a collaborative network of research institutions, community stakeholders to really reduce health disparities. We want to do this through leveraging novel technologies, including augmented intelligence and AI. We have a melanoma community registry of California that we're using to try to enhance the community engagement, have patients participate in our outreach efforts as well as early detection efforts. We're partnering with Oregon Health and Sciences University War on Melanoma, which has a wonderful public health campaign in their state. But Oregon's a very different state than California. It has about 1/10 of the population, and we are much more mixed in terms of our racial and ethnic mix in our state. We want to serve as a model for states that have similar socio-demographics, so that same mix of the population, the same sunny climate, and so on, and particularly the same incidence of melanoma. And then we want to share these materials. So our coalition of academic and health system partners is broad. Again, we are the hub. We started this program. We're working with our partners at Cedars-Sinai, where there's a wonderful Center for Health Equity and Cancer Research. We work with the UCs and the UC Cancer Consortium. We work with Sutter and Kaiser and the other melanoma centers around the country. But you can see, looking at this map, that all of the academic and melanoma centers in the state of California are located in the big cities on the western coast. So we have a very difficult time reaching the more rural populations and counties that are in far northern and eastern California. And why is this relevant? Well, California has the most melanoma of any state in the US. We are the most populous state, so we have the most melanomas. 11,000 new cases of invasive melanoma this year, compared to the entire country of Australia, with about 16,000 cases. There's a lot of work for us to do to try to prevent disease, treat it early, get patients into care on trials, and into our oncology and surgical oncology specialists. We've got to think about different ways to deliver care and provide care in terms of AI and AUI and teledermatology. So beyond our early detection strategies and creating culturally and literacy adapted materials to reach populations in need, we have to really think about the school-based prevention efforts as well. It's been said by the CDC at least 10 years ago that if we were to enact significant primary prevention campaigns with sun protection, we could have averted about 230,000 cases of melanoma this decade with up to $3 billion in initial treatment costs. That's not for advanced disease, that's prevention and first-year treatment costs. So I'm really proud that what the work that Dawn is doing and pleased to be part of it. She's going to talk to you about the creation of ways to reach our younger patients, our younger individuals, I should say, the adolescents who become more resistant to sun protection messaging. How can we reach them in ways that are meaningful to them, particularly with sort of the gaming mentality, virtual and augmented reality? She'll talk about this during what we're trying to do with sun protection education. This is just a picture of our Melanoma Community Registry of California. We've got this translated into Spanish with the goals to translate this into other languages in the state to reach populations in need. And I'll just briefly allude to the fact that we've done some qualitative work to really help us understand the barriers to awareness, prevention, and early detection in populations, non-white populations, the Latino population in particular, which really accounts for 39% of our state's ethnicity. So we really got to think about really looking at the burden of disease, where it's coming from, who's presenting with what types of disease. And we found when we did this qualitative study with focus groups, which again, luckily we completed right before the pandemic started, that of course, access to primary care, dermatology and oncology services are barriers in rural setting, but skin phenotype, the type of skin you have, the skin tone you have can really be a major issue in terms of perception of your susceptibility to melanoma. In people of color, we see lack of trust in the healthcare system. We saw this with COVID vaccinations. And then there's a real issue related to lack of self-efficacy or advocacy to really advocate for yourself, to get into care, to understand what a tumor looks like, what a warning sign is, how to get into the right specialist. And those are some of the things we're really trying to combat in the Wipe Out Melanoma California campaign. We are now working with community health workers in our federally qualified health centers to pilot educational materials. These are translated into informal Spanish, and we go through a lot of vetting of these materials to make them understandable, less intimidating in terms of the scientific knowledge, to try to get people to understand what warning signs look like, and now work with community health workers and other providers to get them into care. And we need the same tailored messaging in Black people. This is another focus group qualitative study that my colleague Eleni Linos conducted, again showing that the awareness that melanoma is a skin cancer and that it can occur in Black people is low. And we need to really highlight that the high-risk sites that it occurs, again, the palms, soles, and the nail beds. About a year ago, we were asked to do out of Stanford the JAMA patient page. JAMA is the Journal of the American Medical Association. It's the most widely read medical journal in the United States. And we were pleased to participate and do this page once again, but we revised it significantly. We're still, again, including those ABCD criteria for melanoma in people with lighter skin or many moles, but we're also including that aspect of clinical warning signs of melanoma on palms, soles, and nail beds, particularly for people with darker skin. Right now, our Wipe Out Melanoma California campaign is looking at engaging nail salon technicians, both in the beauty schools. There's the California Institute or Board of Barbering and Cosmetology, along with the California Healthy Nail Salon Collaborative. And this would really help us, we think, to really look at acromelanoma detection across the board. Acromelanoma is detected late in people, regardless of their race and ethnicity, skin color. It just is a less recognized type of melanoma that occurs, and it can be very difficult to treat. It turns out that there are 500,000 licensed nail salon technicians in the United States. 100,000 are in California, 20% of the workforce, and that the English proficiency is quite low. Only about 50% have enough English proficiency to really talk to clients. And so working with the Healthy Nail Collaborative and others, we're going to try to educate, particularly the Vietnamese speaking groups and Spanish speaking groups, to understand what to look for in the nails, and then hopefully engage their clients in this. And Impact at Melanoma is a wonderful group that's out of Boston. They're a nonprofit. They've done quite a bit with hairdressers and stylists to recognize melanoma on the scalp. And we're now piloting and pioneering this work with nail salon technicians. One slide on AI, because my colleague Albert Chu is going to talk about this. Stanford has really spearheaded some of the AI works globally. And we had one of the seminal papers back in 2017 showing that artificial intelligence-based machine learning algorithms could actually help us detect skin cancer. But we've learned a lot since then. That's been very humbling, and Albert will share that. AI is a wonderful potential, and we've got to figure out where it fits into the milieu of melanoma, early detection, prevention, how we can predict responses to therapy, immune toxicity, and so on. We have our Stanford Translational AI and Dermatology trained team, and our goals are really to advance clinician-driven, patient-centered, responsible, augmented intelligence. So AI that augments our clinical decision-making, doesn't replace what we do. And we're really happy to see what's happening in the field as we move forward. So I'm looking forward to Albert's talk on this. Finally, we have vector demographics, total body mapping, and this has really changed the way we're following patients. There are a number of different types of looking at patients, but this is where we can potentially incorporate AI to help us in clinical decision-making, do less biopsies on harmless lesions, do the right kinds of biopsies on lethal melanomas and not the indolent melanocytic lesions that would never do a patient harm. And even incorporating AI into change detection here will be part of that process. So we're excited about this. We offer this at Stanford for our patients with atypical mole syndrome. It's become part of a standard practice. We're expanding our vector demographics across the Stanford network of dermatologists. In terms of melanoma early detection's future, it's bright. I mean, we really want to think now about screening genotypic patients according to their genotypic, molecular, and phenotypic risk. We want to target those high-risk patients based on their family history, genetics, mole type, et cetera, with state-of-the-art total body mapping and imaging, and then integrate augmented intelligence and machine learning to help us, again, really provide the best care in terms of early detection of more relevant tumors. And in this way, we can still also want to get these patients into care in terms of our oncology side, our surgical side, our trials. So all that we do with early detection, prevention, and community outreaches is really trying to engage the melanoma patient population and their loved ones and being active partners in the system. And so we're very pleased with what's happening with Wipeout Melanoma California, and I really invite you to join the wave if you haven't. We're looking forward to, again, piloting some of our novel technologies in the near future that help us with early detection. And there's materials about this in your folder. So my apologies for the AV back and forth, up and down. I hope that went smoothly enough, but we will talk more at the Q&A, and I'll introduce Albert to come on up and talk about AI. Thank you.
Hi, everyone. My name is Albert Chu, and thank you, Susan, for such a great introduction. And just honored to be on kind of the prevention side to present a little bit of what we're excited about on the technology side to help us here. So I'll be presenting on the realities of AI for melanoma detection. I have no relevant industry disclosures. So I think I'll start off by just an intro to the premise of why we think AI could be so helpful to help us catch melanomas earlier. So I think anyone who's ever dealt with melanoma, whether personally or professionally, really gets that the sooner you catch melanomas, the better, because we know that portends higher likelihood of surgical cure, better outcomes overall. And when we talk about how we do this, lots of people have done a lot of research on how we can orient our entire healthcare system to really help people catch spots as soon as possible. And so you'll frequently see pictures like this, where our current state is where a patient comes in with a spot of concern, and in most cases presents to a general clinician, oftentimes a primary care provider. And then that individual has to make a very astute assessment that, gosh, this spot might be a melanoma, or it might be something else that's bad. And then they escalate that case to a specialist, oftentimes a dermatologist or some other specialist who will help then guide that journey to diagnose and treat that spot. And truth be told, the system can work really, really well. I just want to give a real world anecdote. This is at Stanford Healthcare, a recently diagnosed real life melanoma. This appeared on the back of a gentleman, middle-aged man who presented to his primary care doctor. That primary care doctor did a physical and saw this multicolored irregular spot on the patient's back and had that astute assumption that this is something that might be bad. And so put in what's called an e-consult, where they send a picture over to the dermatologist that same day, highlight his concern. My colleague, Dr. Ko from the Melanoma Center saw this and said, oh my gosh, sound the alarm. Called a bunch of nurses, doctors, I think ended up 3 doctors, 5 nurses, and multiple people at clinics got involved. This patient ended up in the clinic within 24 hours, biopsied, diagnosed with a thin early melanoma. I'm pretty sure Amanda or someone here cured that, or did a surgery in a timely manner. This is exactly how we want this to go for patients with a melanoma. But we know that when it comes to diagnosis, you'll recognize that the dermatologist has the easiest job. Many people have already seen this spot, been concerned, elevated up. My colleague, Dr. Ko, all credit to him, he spends all day looking at skin spots. So to him, he could pick this up very easily. Many of the critical people are that primary care doctor or that patient who maybe has never seen a melanoma before and has to make that assumption that, gosh, this spot is bad, I need to trigger the alarm. So that's where the promise of AI might be. Can you take some of that expertise that lies all the way downstream of the dermatologist and bring some of that up to people higher up who can make that critical decision? Because we know in the real world, across the country, that critical decision doesn't always get made or gets delayed. And that's why we really want to bring that expertise up. So this is what Susan referenced. I think this is where the Stanford part of the story starts. So in 2017, members of our pigmented lesion melanoma clinic, including Dr. Swetter, Dr. Co, collaborated with some brilliant computer scientists at Stanford, and they asked, could AI help us pick out melanomas from normal skin spots? And they showed in this landmark Nature paper that the AI could actually perform at the level of a dermatologist in picking out skin cancers and melanoma from normal skin spots. However, big constraint, this was a very, very constrained, we would say contrived experimental setup. These were textbook historical pictures that were fed into the AI, and then they were tested on that as well. And since then, I think we've become a lot more wise as to what AI can do. So these are colleagues from Memorial Sloan Kettering, whom we collaborate a lot. They have put real world pictures of spots, not classic textbook pictures, to the AI. And what they're finding is that the performance drops significantly. When you take more real world pictures, these are melanomas that may have scabs on them, a hair is going over it, or the lighting is a little bit off. Market drops in performance, and sometimes these algorithms perform very unpredictably. In this case, in one of the top performing algorithms, if they encountered a skin spot that's not been seen before, half of them get called skin cancer, calling it essentially causing a false alarm. So this is why our group has now kind of turned to become a lot more focused on real world testing of these algorithms, understand beyond the hype of that initial paper and these contrived test sets, how would this happen if we actually brought it into the clinic and used it on a patient we were worried about? And on the left is kind of a laundry list of all the reasons why in the real world, spots are way harder to diagnose by AI. One of the big things is that in dermatology, we're not like the radiologists. A chest x-ray that goes through you looks pretty similar here in California, in Chicago, and in New York. But from clinic to clinic, we use different lights, we take pictures with different cameras, patients have different colored skin tones. There are a lot of curveballs that these computer algorithms are being thrown. And as a result, they oftentimes go wrong, or we call it generalizability. They can't perform the same way in which they were developed at our hospital compared to where it was initially made. I just want to walk through one example in detail here, because I think it really shows you the challenge of AI in dermatology. So here's a classic AI diagnosing algorithm. So essentially, it's been trained on tens of thousands of moles, thousands of melanomas. So if you give it a picture of a mole, it's going to be pretty good at saying, hey, that's a mole. But we know in the real world, there are thousands of types of skin spots. And if the person seeing a spot is not quite sure what it is, and they put that into this algorithm, in this case, this is a basal cell skin cancer, which looked a little bit like a mole. And if you put that into that algorithm, which hasn't encountered many of these types of spots, there's a good chance that algorithm is going to say, don't worry about it, it's a mole. It looks just like all the moles I've seen before. So this is why our group, who I'd say, you see that team on the left, that's the group that really opened the door to AI in terms of early melanoma diagnosis. But I think we've also felt the responsibility to understand what are its weaknesses and how do we pilot it so that it can actually be very useful. So this is a big 3-year effort that we were very lucky to have been funded by the Melanoma Research Alliance and just kind of finished, where we partnered with the Cleveland Clinic to really put algorithms to the test and ask what would happen in the real world. So we recruited over or close to 800 patients in over 1,000 lesions. And big picture here is that we recruited them prospectively. So we didn't use historical classic textbook pictures. We said, anyone that comes through the door, if you're worried about a spot, we want to see how this performs in this real world scenario. And then we took 4 state-of-the-art algorithms and put them to the test and compared how they would have done compared to what the dermatologist ended up recommending. And long story short, we saw really big drop off in the performance compared to what they're supposed to do on paper. If you look at the original Nature paper, again, talking about dermatologist level performance, well, you look at that same algorithm, which was actually improved for this study. And what we actually saw is that its ability to detect a skin cancer. So if you have a skin cancer, the chance of it telling you that it was correctly a skin cancer was only 28%. And then what we found is it made a common mistake. It thought skin cancers were inflamed skin spots like acne pimples or eczema. So these are all the things that come out when you really put it to test with real world cases. This happened to all 4 of the algorithms that we tested. And so what we learned is that without further refining the algorithms using technical approaches that kind of tailor it to your local environment, these do not perform well out of the box, which was a little bit of what we're thinking about originally, how to use them. And then one of the big questions we asked is, are these algorithms fair? When we took a look at patients with darker skin tones, we've always been worried that these algorithms do not get trained with enough pictures of patients with black or brown skin in order for them to perform well. So what we did is we took 3 state-of-the-art algorithms and we took pictures of patients who were self-declared black with dermatologist-confirmed darker skin tones. And we took good spots, bad spots, melanomas, and then we matched them to patients with lighter skin tones with very similar diagnoses. And we confirmed the fear, which is that the performance of these algorithms drops off markedly when you use them on someone with darker skin tones. In fact, what we found is that in one of the most vaunted algorithms, again, that sensitivity dropped by 46% of getting a correct answer if you have a skin cancer, if you have darker skin tone compared to if you have lighter skin tone. But the bright spot here is that if you do some technical approaches like fine tuning, where you retrain it on more diverse images of people with darker skin tones, you can completely rescue that drop off. So it gives us a path forward on how to make this more fair. Now, I'll make one final point, which is that I know a lot of people here probably have a burning question. Why don't we just take these algorithms and release them to the general public? Let's just try and get spots as soon as we can. And this experiment has been done in real life, actually, in the Netherlands. So they made one of these state-of-the-art algorithms available to 2 million people in the Netherlands through this insurance scheme. And then a pretty large number of people downloaded it and used it, and they matched it to patients on that same insurance with similar characteristics to see what happened. Well, actually, some good happened. 32% of those of that group that used the app had an increased rate of getting skin cancers or pre-cancers diagnosed. So that's great. That's increased access, earlier diagnosis, hopefully. But a whopping 400% more people ended up at their primary care doctor being told, don't worry about that spot, essentially false alarm, untold anxiety, worry. And they did not even measure what happened to your primary care office. This technology starts sending a lot of people there for all sorts of skin spots. So this is kind of a key lesson. With AI, we're oftentimes going to walk a little bit this balance between increased access and a lot of unnecessary worry and false alarms. So kind of in conclusion here, our team has taken kind of a cautiously optimistic posture. We think that AI can really help us get diagnoses melanoma sooner, more accurately, and faster. However, what we know is this current generation of computer vision AI models, they're not ready to go out of the box. You have to do a lot of these technical approaches to make it more relevant to our local community, to our local environment. And that's especially true if you have darker skin tone. Very, very important. And then the final thing is that no matter how good the algorithm is, depending on where you deploy it, there's going to be a really important balance between making it available and increasing access, and then kind of overloading our healthcare system and creating unnecessary worry. So we think that there's a lot to do here. This is where a lot of our work is now going to be focused on. And we think that having a doctor or other provider in the loop is going to be a way to strengthen this. So thanks, everybody.
So Albert is going to have to run because he got us back on time. Also be cognizant of any question for Dr. Chu that they'd like to ask. Okay, so Sunil.
Care to help care.
I'll repeat your question if it's okay, Sunil. So Dr. Reddy asked whether full deployment to consumers sounds good, but how about relating this to primary care docs to help with triage? And that's exactly, I think, what we're thinking about. Yeah.
Exactly right. I think that's where the whole field is really positioning. We have a lot of studies now saying that AI alone versus that primary care doctor alone, this man versus machine does not work great. But if you have a provider with a lot of experience who has some guardrails and can throw out those kind of oddball results that sometimes happen, that doctor plus AI combination is stronger than either one alone, much better results. And that's been repeated multiple times. So this doctor in the loop, provider in the loop seems to be the path forward. And just the overall premise of getting expertise farther upstream, perfect sense to focus on primary care. So I think that's our next steps in the projects we're working on.
Thank you so much, Albert. I'd like to invite Dawn Siegel to come up, and she's going to talk again about primary prevention education in adolescents. And Dawn, this is what.
Okay, well, good morning. Thank you so much to Susan and AIM for inviting me to share our work with you today. Okay, great. We are developing an educational app for adolescents. Generally, right now, we're focusing on the 14 to 20 year age group. And this is part of a larger program that we have called It's Core, or Interactive Technology for Skin, Community Outreach, Research, and Education. And that program is kind of an overall STEM education program where we've been working a lot with different school districts around San Mateo County, Santa Clara County, and Oakland, as well as Boys and Girls Club of California. But this is sort of a sub-project of that, which is our Sun Safety Augmented Reality app for melanoma education and primary prevention. And our mission is to develop innovative, immersive educational activities to reduce the incidence of melanoma in adulthood, and also improve survival through early detection. So as you've already been hearing about, the primary prevention and preventing sunburns and increasing awareness and education about sun protection early in life is one of the best things that we can do to prevent sun-induced melanoma. And teens who acquire 5 or more sunburns have a significantly increased risk of developing skin cancer and melanoma. We did some qualitative work last year with Alondra Valencia, who was interviewing caregivers. And one thing that she learned, and that's also been shown in the literature, is that another really great aspect of this educating teens is that we might also be able to educate their parents, because it turns out most parents will do things to kind of role model good behavior and healthy behaviors for their kids. And so they might put on sunscreen or do sun safety practices in the hope that their kids will as well. So there's kind of a double back and forth with this as well. And so public health interventions for children may be a really good strategy to impact melanoma prevention. And we're developing, I'm going to tell you, my talk today is going to be about our process and how we're going about developing these tools and this app. And we really want to develop effective targeted primary prevention tailored to the learning needs of this younger age group. And we know that they kind of learn differently and different things appeal to them than maybe just a handout or a lecture or something like that. And so we really want to make this a lot more fun for them to bring them in. And studies have shown that visualizing the impact of health choices can positively influence learning and behavior change. So that can be with different apps or different tools that kind of demonstrate so that kids can visualize what is happening when I get UV radiation on my skin. How is that damaging my skin? And I'll show you a bit later, but they really actually were excited about seeing skin cells under the microscope in this 3D world. And so this is this picture with the skin. This is kind of, it's what we call solar elastosis, but it's rather than having these nice pink healthy fibers in the skin, they're kind of all these blue melted skin cells and fibers. And we're working with a really fun undergraduate student from Peru right now, who's bringing just wonderful ideas. So he's developing these animated characters, and they're going to be giving the lessons, and it's a lot of fun. So this is one of his characters as well. This is Intio, the son, who's going to be teaching some of these lessons. But we know now that there's really a need for far-reaching educational platforms to raise awareness and educate on sun protection and melanoma awareness. And this is in the 14, as I mentioned, we're focusing on the 14 to 20-year-olds at this time. So our first application that we started developing is with a computer called Z-Space. And this is a technology, it's a computer that has a 3D technology. It's really, really neat. And anyone is welcome to come and visit us, and we could show it to you. But basically, It's like virtual reality, but you don't have to put on the goggles, which is kind of nice because then teens can be like in a classroom environment, could be interacting with their teachers and their peers and not kind of closed off with the goggles. But you can move things in this 3D world and it looks like it's in 3D hanging in front of you. It's really neat. And so they're fully immersed and engaged in this. They think it's really fun. And they also can dissect skin in this. So they can do little skin dissections and cut through it and take it apart and see all the different skin cells that way. One thing that we're trying to learn about through this process is how much to teach about recognizing melanoma. You just heard in the last talk from Albert about how you can also like raise undue anxiety or concern. And so in this kind of sensitive age group, we're really focusing mainly on primary prevention, maybe just with just a little bit of information about how to recognize a skin cancer or a melanoma. Sorry, not too far. And so this is kind of how our app works. We're going to have a couple different forms. One is on that zSpace computer, but then you need to have that specialized computer. And so we're also developing a model that's going to be usable on Android and iOS in like an iPad type of format with augmented reality filters. So this will be much more broadly accessible. And we're using AI to develop different personalized avatars. We're making this decision. We want to appeal to a wide range of kids, and we want them to be able to create avatars that look kind of like themselves, or just pick someone who they think would be fun to use in their virtual world. For privacy protection, right now we're not building it to have kids take a picture of themselves, but that's kind of why we're going with this AI-based model. And then they can do fun things like change the hairstyles and change the facial expressions and things. And then we have different prompts where they can spray on sunscreen to practice doing that, getting the ears, getting the neck, different areas they might forget. And then a reminder that it's time to reapply, and then they have to do it again to try to teach that technique. This is just a picture of the sun that's part of the 3D model, and they can watch little videos, which they love, and then they can also take this apart, and then they're learning about what is UV radiation, how does it affect the skin. And this is another part of the app where they can have a mannequin where they can put on different hats, different sunglasses, and they have a lot of fun dressing up the mannequin. And then this is demonstrating what I was mentioning about dissecting the skin. So here's where they can kind of learn about the different skin cells, learn about melanocytes, have a big part about melanin. We're very interested in reaching kids with different skin tones. And so you saw on the last slide that we kind of divide these skin tones into like type 1 and 2, which is really light, and then 3 and 4, which is kind of medium, and then 5 and 6, which is really dark. And we're going to create these personalized pathways in our educational app so that it could be like, if you have type 1 skin and are at very high risk of sun-induced melanoma, these are the messages that are important for you. And if you have very dark skin, then we're going to have a slightly different message. This is just an example of one of the avatars that a student might create, and then they could put on all the different hairstyles, which is fun. So in our pilot data, we tested, in our preliminary group, we tested our just kind of beta version of our app with about 35 students. And 90% did say that they thought augmented reality would be very helpful to teach about their skin health. And 92% said they will now think about protecting their skin from the sun after using the app. So that's just kind of a first step. They're going to think about it. That's a win. But future long-term goals would be like clinical trials, where they come back 3 months later and did they actually change their behavior to start protecting their skin more? So far, we've reached a wide range of students from different races and ethnicities and backgrounds. 96% of our participants reported speaking English, 35% also spoke Spanish, 6% spoke Mandarin, and 3% spoke Tagalog. So we're eventually our goal is that we could also add different languages to our app. This is a slide demonstrating our results that I had mentioned earlier, just showing that we pretty much doubled the percentage of kids who would think about wearing a hat, wearing sunglasses, seeking the shade, and wearing sunscreen after using the app. And then when asked about how do you feel about using augmented reality, it was interesting because I think not as many kids are familiar with augmented reality. Kids are most familiar with virtual reality and wearing the goggles. So when we had kind of asked beforehand, which methods would you like to use most, you know, videos, games, augmented reality, virtual reality, they all said they would prefer virtual reality. But after testing the augmented reality app, they did have an increased interest in using it and did say that they thought it could be very helpful. We also sought some qualitative feedback from our team participants in terms of which parts of the app were most helpful. And they mentioned that visualizing, as I said before, visualizing the impact of sun damage on the skin was helpful. So really looking at it on a cellular level, especially in the high school age group. Practicing sun safety behaviors, like putting the sunglasses and the hats on, and then identifying the different layers of the skin. They really liked being able to take apart the skin and dissect the skin. When we asked them what suggestions they would like to make it more fun, they said they wanted more games. And so our student this summer is really doing a great job of coming up with all these fun ideas for mini games so that we could kind of give the educational message and then they can test their knowledge by playing different games. We've also talked to educators about, we heard earlier that there's really a lack of information in kind of K through 12 education about sun safety and skin cancer prevention and skin health. And so we're following the California science standards. We were collaborating with San Mateo County Office of Education on developing these. And we've been doing interviews with educators in middle and high school. And they said that they would really like to use these new technologies for their content in the classroom. So the impact of our app is that we are hoping that we can have it in school science and school health curriculum, that we can have it in after visit summaries for like the patient handouts that they get. There could be a link to the app, you know, where you could download it on the App Store and then play the game at home, we hope. And that it will be free and publicly available to maximize the use of it. And I just want to thank all of the expertise and the depth of our experience at Stanford with Serge and Albert, Justin Chu, Wipe Out Melanoma with Susan, Virtual Human Interaction Lab with Jeremy Ballanson, the Chariot Program with Tom Caruso, and then the Center to Support Excellence in Teaching with Janet Carlson and Preetha Menon. And so we're based at the Virtual Human Interaction Lab, and so you are definitely welcome to come test the app. Anyone can come set up a tour, and yeah, we'd love to hear your feedback. And thank you to all the funding sources who supported our development.
Any quick questions for Dawn, or one question, or we'll definitely have ability to answer some questions too in the chat, but very excited to be to pilot some of this on Wipe Out Melanoma. Thank you so much. Okay. I'm sorry. Go ahead. Yeah.
I'm big comment. This should be incorporated general educational course kids. They don't know about primary cancer with HPV vaccines. They don't know about proper diet, cancer. We really need to re-educate. This is a great start. It should be incorporated in wider.
Totally agree, Dan. I think we've talked a lot about bundling, you know, even early detection programs of prostate and other things for screening, but the education is just fantastic. Please introduce Pauline Bunchain. She's going to talk about genetics and melanoma, family perspective.
Good morning, everybody. Thank you so much for showing up to learn more about melanoma. And hopefully with this talk, I get asked a lot, and many of us get asked a lot, what about my family? What does this mean for my family? And so hopefully this is something where, I see some people, hello. This is a question we get asked a lot, and we had some answers, and I'd like to tell you a little bit more about what we found recently about families. But hopefully this is something that not only keeps you safe, but your family members safe as well. So we are going to start with just talking about family, right? Why do we ask about family? Because families share many things. Great hair. Business acumen. Okay, but in regards to melanoma, families share melanoma risk factors. So sun-sensitive skin, fair-colored eyes, red hair, freckling, having a lot of moles will run in families. So there are things about skin and coloring that can increase the risk for cancer all in and of themselves. But what was interesting was, so I came from a inherited genetics background before I came into melanoma. And when I came into melanoma, and I started asking about family history because that's just something I was used to doing, there was an incredible number of patients who had a family history of cancer, and not just any family cancer, but what we would consider a significant family history of cancer, 3 or more people in the family with cancer. And so when we saw this, I said, wow, this is actually different than many of the other cancer clinics we have in breast cancer, colon cancer. It's not almost 30% that have 3 or more cancers in a family. So something just felt more familial than skin color, hair color, all of those things. And around that time, there was a very interesting Norwegian twin study. And so they had, in Scandinavia, they keep a wonderful track of their medical records and their families. And so they were able to look at twins, both what we call monozygotic or dizygotic, so that means identical or fraternal twins, a huge set of twins. And they did a statistical calculation of what were the most heritable cancers between twins. And it turns out that melanoma is the most heritable cancer between twins, right? And then also prostate cancer and leukemia. And so this was coming out all around the same time, and it looked like, look, there's more to melanoma, I think, than fair skin and fair hair. So we decided to get it. So myself and a dermatologist, this was back when I was in the clinic, we decided to open up a registry. We thankfully had a very philanthropic family in Cleveland who was really interested in family, very, very strong family culture, and also had a family member with melanoma, and they were very interested to help this project along. And just for folks in the room, you have an interesting thing, something that you're really interested in and really passionate about, you can make a difference. And I'm going to show you what the Gross family did for this project and for sort of science in general. So we offered free genetic testing. There were 12 genes that were already known to be related to melanoma. There were 70 plus genes that were related to any cancers, but not known to be related to melanoma. For all these folks, we drew out a family tree. We made sure that any genetic counseling that was involved would not be at cost for the families that participated. And then we did ask our participants to just donate a couple more tubes for science of blood. And they very kindly did. So what we did was we expanded on what was known. At the time, it was said 3 or more melanomas in a person or family, that's it. And many people even said, don't try testing, because if you test, you're just going to know that there are melanomas in the family, and there's nothing you're going to do to change their treatment or change anything for their family. So this was done in Ohio, less sun. So we figured there'd be fewer melanomas. So instead of what's traditionally called the rule of 3, we did the rule of 2, less sun, less melanomas. But we also wanted to look at other cancers other than melanoma. We also looked at people who were young, and we also looked at people who didn't have a family history. Maybe they were adopted, maybe they were an only child, maybe their parents were only children.
but we just wanted to get as much information about who might be at risk. And then, so this we presented about, well, a year ago, but it's just published this year. Lots of people involved. And what we found, so this is where it gets a little dense with the data, but let me sort of explain. So of all the people that underwent testing, 400 people underwent testing, 15% had something that ran in families, okay? That is 1 in 7. So of all the people we tested, 1 in 7 people had something that not only had to do with their cancer risk, but also their family members' cancer risk. And what we found much more, from a scientific point of view, much more interesting was that last bullet there. 67% of these findings were in genes that we had not associated with melanoma before. So we said, wow, these are genes we didn't even know were associated with melanoma. Most of the time, we're not even testing for them. You know, I remember when I started, people would come up and ask, what gene should we test for melanoma? I mean, we'd be like, well, there's these 3 genes and these other ones that are super rare, but not a whole lot of genes. We didn't actually really know what to test. And now we know that we're testing not enough genes. Can I tell you which genes we absolutely need to test as of today? I don't, but it is wider than we thought. Okay, and so again, sort of more scientifically laid out, let me explain. So these were the reasons that people got into the trial, okay? And these are folks who actually had something run in their families. And what were the most common reasons they were tested, essentially? And the most common reasons, so the thinking at the time was you were looking for melanoma. But it turns out the 2 most common reasons why people got tested had to do with melanoma and other cancers. Melanoma and breast cancer, melanoma and colon cancer. And these were the questions we weren't asking. All of our automatic notes in dermatology or oncology are, how many people in your family have melanoma? How many melanomas do you have? But in our automatic notes, there was no question about, do you have other cancers in your family? Is there breast cancer in your family? Is there colon cancer in your family? Is there thyroid cancer in your family? That's not in our automatic notes because that's not what the data we had before that. So this then is making us think that what we need to do is when we're in a clinic with all of you all, we should ask these questions. And if we don't, remind us, you know, it's not just melanoma. I also have these other cancers in my family. And so just again to say that these are the, you know, of those 67% of genes that we didn't know had an association with melanoma before, those are all in bold here. So you can see that there are plenty for cutaneous or skin melanoma. But there's also things that we weren't expecting. We didn't know that there was such a thing as familial melanoma if it has to do with mucosal melanoma. That's the inside of your skin. So like inside the nose, inside the rectum, that type of melanoma. We didn't know, there were a couple of genes we knew that were associated with melanoma of the eye, but this was a much broader spectrum of melanoma of the eye. And then unknown primary, there are a couple more we weren't. So essentially, all the melanoma, all the different types of melanoma we tested had some familial relationship. And there are a lot more genes that we just had never been looking for before. And so our keynote speaker also did another set from his institution, which thankfully said the same thing as ours. So totally different state, totally different type of testing. And they also found in all of their melanomas, so a bigger data set than ours, but 700 patients in this case. But 1 out of 7 or 14%, 1 out of 7 of these folks had melanoma. And this is a totally also different reason for testing. So we had these very clear criteria. Their criteria were a little bit different, but again, they got very similar. And they also found that all the different types of melanoma, skin melanoma or cutaneous, mucosal melanoma, uveal melanoma or melanoma of the eye, they all had some relationship to familial melanoma. So we're seeing that there is a reason for testing. It used to be said that there wasn't a reason for testing, and that
the reason for testing means that we may find people who are at risk not only for melanoma, but for other cancers in them and also in their family members. So why do we do this? So I always like to do a little bit, because not everybody knows about what happens when you find something that runs in your family. How does that help? So it helps because even if you have had melanoma and you are found to have an inherited cancer predisposition in your family, you may be at risk for another cancer, and we can look for that. So if you had a stage 1 melanoma, you've had it all out, we really don't think that, there's a very, very tiny risk that that melanoma could spread. And we're really not really worried about that. There's a chance that a person who carries something through their family may be at risk for a different cancer, breast cancer. Maybe that person should get a screening MRI or a screening mammogram earlier. So this can actually help save, for the person who finds out that a cancer runs in their family, that they can actually prevent or find cancers earlier when they're less risky. We just heard Dr. Swetter talk about what happens when you find cancers earlier, at earlier stages. At that point, it's much more curable, right? So even for someone who has melanoma, this could help save lives. In family members who have never had cancer before, but find that they are a carrier, they can go through all of that proactive screening to find cancers earlier, even prevent cancers. And for people who in the family who get tested and find out they're not carriers, then they're at general population risk, and that can be very, okay. So knowledge can save lives. Knowledge is a little scary, but it can save lives. So this is a patient who participated in the registry. He asked me to, whenever I talk about the registry, please always tell his story, and I am keeping to my promise. So this is a gentleman who was diagnosed with stage 3 melanoma. He enrolled in the study. He was found to have an MSH2 mutation. So this is a mutation for something called Lynch syndrome. It increases the risk for colon cancer and sort of GI cancers. And a couple of years later, as we were doing scans for his stage 3 melanoma, we actually found pancreatic cancer. That pancreatic cancer was borderline resectable. He went through a clinical trial and it didn't shrink. We could not get that pancreatic cancer out. So at this point, it's what we call unresectable, or pretty much sort of stage 4 pancreatic cancer. For those of you who aren't familiar, that's a terminal diagnosis, and that unfortunately the survival is not super, super long. But because we knew he was MSH2, we put him straight on immunotherapy, because there is, for Lynch syndrome cancers, immunotherapy can work. He actually completed his immunotherapy about 1.5 years ago. He's now sort of living with pancreatic cancer. It's been 3 years. It hasn't grown. It might be not there. It just might be radiologically there, but he is thrilled, and he wants everyone to know this is how we can save lives when we diagnose something that runs in the family. All right, so just a little bit about genetic counseling and testing. If you were curious, if you were ever to ask this question and want to know more, this usually involves getting a little bit more information about testing. That's pre-test counseling. That is drawing out a family tree, figuring out what to test for, education about the testing, because there are things that you will find out you won't find out about testing. If you're eligible for testing, then it's a blood draw in order to test. Occasionally, there are other ways to do this, like Swetter. And then if there is something that runs in your family, you get lots of information that you can pass out to your family members, that you don't have to just write it down and record it and figure it out how to pass it on. It is part of what genetic counseling does, give you all that information, print it out, multiple copies, so that you can give it to your family members, and you don't have to explain. The other thing that I think is really important to know about genetic testing is that it's yes, no, and maybe. Okay, so there is something that runs in the family, nothing runs in the family for you, or there's something in between. So this is the way technology works nowadays. It's not always black and white. There is a gray. Most gray is considered negative, but just so you know, this is what happens in genetic testing. In some risk for melanoma and other cancers does run in families. It is good to know these things because it can potentially save a carrier's life as well as their family members' lives. And at least what we know so far based on our work and Dr. Shushtar's work is that if 2 or more melanomas or multiple cancers plus melanoma run in a family or person, that is a really good time to ask, should I get tested? Okay. The last thing I just wanted to say is Angelina Jolie, if any of you are familiar, she is a BRCA1 carrier. Her mother died of ovarian cancer in her 40s, and she got diagnosed with breast cancer in her 40s. And I love this quote from her that, as you all know, everyone's in this group because you've been challenged in some way, shape, or form by cancer. And there's a lot of things that we cannot control, but the things that we really should not be frightened of are the things that we can control, that we can test for, that we can get help. These are thanks to my teams.
Thank you so much, Pauline. And Pauline will be here for the panel, so we'll address any questions. And I just want to say, as an author on one of the original Rule of Threes paper, which probably came out a good 15 years ago, new knowledge means everything. So thanks to Dr. Spanchain and Shushari and others for really looking now. It will probably be a new Rule of Twos in the guidelines for genetic screening. So very pleased to introduce Amanda Karani, who joined us again for surgical oncology leadership. And she's going to be talking about the new upfront approaches to therapy we see, particularly for nodal disease. Amanda.
Thank you. Good morning. Hi, everyone. Oh, it is such an honor to be with this team and to be able to talk to all of you this morning. So my title is a bit of a deeply nerdy inside joke about adjuvant surgery because there really is no such thing. And this term was coined by one of my favorite mentors, Dan Coit from Memorial Sloan Kettering in 2017. It will surprise you that surgeons very arrogantly think surgery is the only tool in the toolbox. And so for many decades, that was the mainstay of how we treat this disease, and everything else is the adjuvant. And with the advent of immunotherapies and some of the things that I'm going to talk to you about, that script has finally flipped. And anyone who knows me well knows that one of my career goals is to eliminate my job. And so I want to talk to you about why I think that's going to be possible in my lifetime. And so the mainstay of the type of immunotherapy that we mean here is medication class called checkpoint blockade therapy. And with this therapy, it has just changed the way we not only treat melanoma, but how we even think about what cancer is. And until this drug class became available, surgery really was the only thing we had to offer. And so when I was asked to talk about what's new in surgery, my answer was very little changed about surgery. Barbaric. It's been the same as long as we can think of it. But this is what has changed and how we approach surgery and when we need to use surgery. Because when we talk about adjuvant therapy, the standard nomenclature is that surgery comes first and then adjuvant therapy are the medications that we add afterwards to prevent the disease from coming back in the future. And so this medication was the first to show us that after surgery, we could improve survival and we could truly make a difference in the outcomes for the disease. And so the NCCN guidelines, which all of us use to guide our care for patients, have rapidly changed already once in my career, which is why I'm able to conceive of these things changing again and again for us, such that when I gave a talk very similar to this even just a year and a half ago, the guidelines said that we could consider in the context of a clinical trial, we should really think about using these medications first. But it certainly was standard, whereas now in just a year and a half, this is accepted as the mainstay of our frontline approach for patients that present with advanced disease or have melanoma already in their lymph nodes when they come to us. And so this is what it looks like when your melanoma doctors get excited. The medical Twitter just exploded with these trials, and I highlighted some quotes that this was just incredible. Their minds were blown, game changer. You could drive truck through these curves, and my friends, talked about this over and over again because those of us in immunology had always thought that giving the medication first should work better. but we finally had the evidence with this trial. So just to briefly tell you about the science of why we think this should work better. These checkpoints are molecules on the surface of tumors and immune cells that turn the immune system off. And the analogy we frequently use, they're like the brakes on, so that when these molecules are engaged, that the immune cells stop working effectively. So when we bring these drugs in, these checkpoint blockade drugs in, they take those brakes off so that the immune system can return to attacking those tumors. Now, unfortunately, that's a non-specific process. So it comes with the side effect of then activating your immune system all over your body. And you can have what we call immune-related adverse events that can affect anywhere in the body, really. And so the balance is trying to judge how do we get the maximum impact on your immune system without causing these side effects. And so that's when we talk about the rationale of using the medication up front. Because historically with chemotherapy, we thought that, with chemotherapy being toxic to most cells in the body, that ideally we should remove as much of the tumor as possible. And by leaving only a little bit of tumor to attack, we can use less chemotherapy. But with immunotherapy, we want that tumor intact so that your body can learn to recognize that melanoma and in effect become vaccinated against it, if you will. And so not only do we think you'll get a stronger immune impact, but it really helps us surgically. It can reduce the size of the disease so that your surgery is smaller and has less risk of having an injury with surgery. And it also gives us important information about how you respond as an individual to this type of therapy. Because if you think about the alternative, where we remove the tumor first, we will treat with a standard one-year approach, but we really don't know how much impact that's having. And so, we've used this in several different iterations with the older classes of this medication. And unfortunately, that side effect profile was too large for us really to implement this in a standard fashion. And so with this new trial that I was mentioning, the SWOG 1801 that's been out for the last 2 years, this had used the current mainstay of therapy, which is a single agent called PD-1, and had properly asked the question by randomizing patients to have surgery either before or after 2 months of therapy, and following them longitudinally and then continuing the therapy for a full course of a year. And the results were impressive. It was very clear that the patients who received the therapy first had a better effect, consistent with what we expected. And what's really important about these curves is you see them flatline. And that's how you know these types of therapies are working, is that the body maintains that memory immunologically. And the important questions then that I get asked in the clinic is, well, what happens if it doesn't work for me? And what are the chances I'm going to have a side effect that's going to be devastating from this therapy? And so in question number 1, the number you want to know is 8%. It was only 8% of patients that did not go on to receive the surgery they expected to have. And what's important in that number is most of those patients actually had a progression of their disease outside of the original surgical field. And so those were patients, we needed to know about that. Those are patients that need to move on to what we call early, some of the other types of therapies that Dr. Bedoff-Warner is going to talk to you about after me, and need to move on to something else other than surgery. And we don't want to waste time using the wrong therapies or taking the wrong approaches. And the other good news was that the side effect profile was fairly low, and it's essentially the same. So whether or not you use the therapy before surgery or after surgery made no difference. And so as Dr. Fontaine alluded to, though, one important consideration is that our imaging hasn't really caught up with this therapy, so that when we look at the PET scans or the CT scans, we may not really know if what we're seeing is immune activation just from being on the therapy, or if it's actual resolution of the cancer. And so to this day, it remains important that we still obtain pieces of that tissue, if not perform the same surgery, because that's probably question number 3, is if I'm having a great response, do I still have to have this surgery? And so far, we think the answer is yes. In particular, so that we can keep learning about who this therapy is for and what it looks like when someone is not a responder. And so overall, the takeaway of this study was that we feel this should be the standard approach for most patients. It is safe and it is definitely having an impact. And so this has been repeated in other study designs with other agents. This study just came out this summer, the Nadina trial, that goes back to using some of those original drugs, the CTLA-4, just changing up the dosing and changing up the approach. And it's been proven highly effective. So now we have an extra confusing question about which variety of the therapy is going to be best for you. And then there's another class of agents, which is a particular interest of mine, which is giving the therapies directly into the tumors rather than by IV. And so we've run studies using a kind of medication that you inject. Here, this type that I'm describing is actually a virus that infects the tumors preferentially and then causes those tumor cells to break open and release all those antigens, teach your body to recognize what melanoma looks like, and then stimulates an immune reaction that can be persistent in the sites that we don't inject. And so, well, this is imaging from one of our cases at UC Davis. We used this type of therapy in a patient that had a recurrence of their melanoma. You can see an extensive area that would have been very difficult to perform surgically. And so we inject this medication for a number of weeks, and we see here a complete resolution of the tumor. You're actually left with some pigmentation, like a tattoo, which can be interesting. But overall, this patient went on to be disease-free for 5 years and never went on to receive the checkpoint therapies and had no side effects from this approach other than the wound care needed in the beginning of the treatment. And so then this is also an example of what that can look like, that abscopal effect, where we see sites that we don't inject respond. So this is a patient that had a neck tumor injected only and also had lung disease. And over the course of a few weeks, we see the lung disease go away as well. Now, unfortunately, that part is not good enough yet. It doesn't satisfy us. It's maybe about 10% of patients that can expect to see all of their tumors go away just by injecting one single site. But we're getting better and better at this with every generation of this drug. And so there'll be more and more trials coming down the pipeline. But we have studied it in this specific scenario, this neoadjuvant scenario of can we then harness how well this type of medication works by injecting the tumor before surgery and generating an immune response before we ever take you to the operating room. And it turns out the answer is yes. And we saw about 20% of patients have a complete resolution of their tumors before they ever got to the operating room. And so the questions that remain are which therapy is going to be best? And the answer is we don't quite know yet. Can we avoid surgery? Which I think one day absolutely, but not quite yet. And that can we de-escalate how much therapy you need based on what type of response you've seen? And then this is data from that Nadina trial showing the differences between patients that have had a complete resolution of their tumor versus partial versus a progression. And you can see that the patients that had the response, we know how well they're going to do. Now, the question that remains for me, while I have many wonderful colleagues answering the question of how do we make these therapies better or how do we reduce the side effects, my question is how do we know what's going to happen to you when you come into the clinic? And you know, my husband is here today because he can tell you that one of my least favorite responses is I don't know. And this is an area that we really need to work a lot more on longitudinally studying this tissue before and after the therapy. And so that's what my lab does in collaboration with a lot of people here on campus. So we do two varieties of studies. One is to take the tumors and create many patient avatars that we call organoids. And when we can study those in a dish and give all these same therapies and therapies that aren't going to be available for 10, 15 years and try them in a dish and see what happens. And we can also then manipulate the tumor and change the cells in it and change the way the stroma works and all sorts of features and run many clinical trials in a dish way ahead of what we can do in the clinic. We also work on very novel optical imaging techniques so that we can dive into this tumor tissue in a way that hasn't been done before and classify which molecules are most important in each individual tumor, and then feed all of this information back and forth into the AI and machine learning that we've talked about a lot today, so that we can find even the tiniest signals of what's going to predict what's going to happen for our patients. And so we've started to learn more and more about what the difference looks like between a patient that has a response and a patient that doesn't respond. So that then we can move into the next step, predicting, well, what other therapies should this patient be seeing? And so ultimately, that is our goal, is to create these biomarkers and these tests, and we're coming a long way very rapidly. And, I'm really grateful to many of you who have contributed to this work, and your tumors are in our lab working on this, and we just deeply, deeply appreciate your willingness to help us move the needle to these.
Thank you so much, Amanda. And we are, I think, still on time. So very, very pleased to have Alison Betta-Warner come up and talk about tumor-infiltrating lymphocytes and melanoma, the newest immunotherapy kit on the block.
Thanks, Susan, and thanks to all of you for joining us today. It's really such a pleasure to have a chance to talk to you about what is the newest therapy, the newest FDA-approved therapy for metastatic melanoma, and something that I've been working on now for many, many years. So to see it come to fruition, and some faces in the room that have even had some discussions about this with me. So we will talk about TILs, or tumor-infiltrating lymphocytes, but to set the stage for that, I think it's important to understand where we've come. And where we were maybe a decade and a half ago to treat metastatic melanoma, when all of the prevention strategies we've heard about, we progressed past that, we progressed past this early treatment stage where melanoma is in a lymph node, and now we're stuck with melanoma that has spread in the body. And now what do we do? So if you had come to one of our clinics, 15 years ago, we did not have any of the immunotherapy strategies that you've heard about today. We did not have the targeted therapy medicines that we talk about today. And we were stuck in an era where we used chemotherapy for this disease. And that was one of two medicines, but predominantly a medicine called the carbazine, which you will very rarely ever hear us mention in our clinics anymore, which is a wonderful step forward for us. And so if you had come to our clinic at that time and asked us, doctor, how long could I expect to live? The average was about 6 months. And that was the best that we could do. And now with the improvements that I just talked about, immunotherapy, targeted therapy strategies, but particularly this combination of ipilimumab plus nivolumab, if you are newly diagnosed with metastatic melanoma, and we offer you this combination of ipilimumab plus nivolumab, the average survival went from 6 months to over 5 years with one drug combination approval. And that is truly incredible progress in a decade and a half. But I'm going to make the argument that that is just not enough. Right? So when we look at these curves, these are what we call overall survival curves, and anything under those lines, right? So that red line here is that red combination of ipilimumab plus nivolumab. Anything under those lines are patients doing really, really well, surviving, doing well from their melanoma. But those lines aren't flat, and there's still areas above those lines where we have patients who aren't surviving their melanoma. And that's what I'm really going to talk about today, is what do we do for all of these patients? When that treatment does not work, where do we go? And this, to me, is where TIL therapy fits in. So TIL stands for tumor-infiltrating lymphocyte. And that's a big fancy word to say when I take out a tumor, I find these lymphocytes or immune cells in that tumor, shown here in purple. And in theory, those lymphocytes or immune cells have the ability to treat or even kill cancer. But for some reason, if I take out a tumor in a patient, they aren't working. And there's a variety of reasons why that might be true. But one of the reasons is there's probably not nearly enough of them. And so the idea behind TIL therapy is essentially to take out a tumor, find those lymphocytes, expand them into the many billions of cells, and then give them back to a patient. And many of you have probably heard of something called CAR T-cell therapy, or even TCR therapy, and it's a slightly different approach where we take out naive T cells from the blood, and then we put on a receptor that tells those cells to go after cancer. And that is certainly something we're working on, but as of yet, we have yet to find a CAR T cell that does much for melanoma. So that strategy is certainly something we're working on, but that's not yet ready for prime time. But TILs, they're here and they're ready. So what this process looks like, again, patient undergoes a surgery. We take out a piece of tumor that's somewhere between 1.5 centimeters and about 4 centimeters of tumor. Dr. Karani does a wonderful surgery and then chops up that tumor into little pieces. We find those immune cells in the tumor. We send this at present off to one of several companies, but the company with the FDA approved drug is a company called Iovance. We ship this off to them. They basically separate out the tumor cells from the immune cells, grow up the immune cells in many, many big petri dishes, test them to make sure that they're safe and pure and not infected and all of those good things, and then put them in a bag, freeze them, and ship them back to us. Once we get those shipped cells back to us, we take a patient, we say, great, we are ready to go. I've got my frozen bag of cells in my hand, and we start this process. And that process looks like an initial 5 days of chemotherapy. And that chemotherapy doesn't treat your melanoma. What it does is gets rid of all the immune cells and all the other competing things that would make the TILs, the good cells that I'm going to give back, not work for you. Right? They get rid of the competition. And then we give the immune cells, the TILs, followed by a medicine that is called high-dose IL-2. And you actually heard Susan mention high-dose IL-2 briefly. This was a treatment we used to use in and of itself for melanoma, and it was a really tough treatment. The amount that we give to stimulate the TILs is a much lower number of doses. But it is critical, at least at this point, to make those TILs healthy, happy, take hold in the body, and actually start to expand on their own and trigger a big immune response in the body where those cells can specifically go after your particular tumor. This all takes place in the hospital. Patients are in the hospital somewhere around 2 weeks, around that period of time, while getting the chemotherapy, the cells, the IL-2, and then recovering from side effects of all of those things. And we'll talk through a little bit of each of those. But I think the first question is, how well does this actually work? So these are big fancy plots that we use as oncologists all the time, but essentially you see a big flat line down the middle. If anything is going downward from that line, that means tumors have shrunk. And anything that's going upward from that line means tumors are growing. So I think just on a large level here, you can see that most of the lines are going downwards, and that's a very good thing for a drug, right? That means that drug is working and melanoma is shrinking. And you see this sort of faint gray line at that 30% cutoff. That is the magical number that as oncologists we use to say, yes, we've seen real tumor shrinkage. So when we say partial response, that is 30% shrinkage or more of a tumor. So if we look at the numbers from the what's called C-14401 trial, but the trial that led to the approval of this drug, like Palo, or its trade name is Amtagvi, right? 6% of the patients had their tumors go completely away. 31% of the patients had their tumors shrink or go completely away. But I think really promisingly, in addition to those numbers, which are good but not good enough, is that nearly 80% of our patients had their tumors stabilized. And while I wish that that was 80% of our patients that had their tumor shrink or go completely away, if a tumor stabilizes and a patient is doing well, that is a big, gigantic win for us when patients have progressed on other standard therapies. And prior to this, and quite frankly, other than this, we have no other drugs that we know of today in 2024 that have had anywhere close to this type of result for melanoma that has progressed on standard immunotherapy. And I think equally promising is that this is a one-time treatment. So we typically think of treatments that you get every 3 weeks or every 4 weeks or every 6 weeks, right? Chemotherapy, immunotherapy, targeted therapy that our patients take every single day, right? This is one big, tough several weeks or months, but then that treatment is ongoing for weeks, months, and potentially even many, many years. And that is the true promise of a cell therapy approach. This is a one-time treatment. And in this trial, of the patients whose tumors shrunk and responded, 42% of those patients had not needed any additional treatment for their melanoma at 18 months. And that is the published data. We now have updates at 2 years and beyond. And we actually all, anyone who treats melanoma in the room know of patients who are 10 plus years out that have not needed any treatment. So again, a really tough several weeks. It is a big treatment. It is not a small undertaking, but the potential at a one and done type of approach for melanoma. And this is why we are so excited about it. So what are the side effects? Why is this such a tough couple of weeks? So a lot of the side effects are related to one of two things. So one is the chemotherapy. So the chemotherapy is needed, again, to wipe out all the competition, but chemotherapy comes with chemotherapy side effects. So hair loss, the potential for nausea and vomiting, although we now have very, very good medicines that help to prevent that, let alone treat it, but actually prevent the nausea altogether. But the biggest risk of the chemotherapy are the risk of getting an infection because we are knocking down your immune system, and the risk of bleeding because a lot of the clotting cells in your blood will also go away as a side effect. The other big risk is actually that IL-2. So the cells themselves actually have very little risk, but the IL-2 medicine is really tough, right? It causes high fevers and shaking chills. I always tell my patients, like, if you've ever had a terrible flu or COVID, right, and you had high fevers and shaking chills, that actually was your body making IL-2 to try to stimulate your immune system to treat that virus. We give that medicine in higher doses. So in addition to the fevers, the shaking chills, IL-2 is a medicine that causes the fluid to sort of leak out of the bloodstream. So the blood pressure can get low. We can have tough effects on the kidneys and other organs. This is something we monitor very, very, very closely. But I think one of the most important things to know, and can you see the pointer? One of the most important things to see here is this huge spike in side effects, right? The rate is certainly high, but if you look, it is almost completely gone after day 14, right? Day 14 or day 15. And that is the time that you are in the hospital being monitored very closely under our care. And we have medicines that treat a lot of these side effects. So any of you have heard me talk about this. I always say this is a really big hammer, but it's a really big hammer for a big nail, right? This challenge of melanoma that has progressed on standard therapies is a big challenge. This is a big hammer to treat that big nail, and it is not easy, and not every patient is appropriate, and we'll talk about that. But this is one of the most exciting things that has happened to us in the melanoma field in many, many years. There was a second study that studied TIL cells, slightly different, not made by this company, but essentially the same process, and actually compared it to ipilimumab directly for patients who had had only single drug PD-1. And what you can see here is if we look at TILs in yellow versus ipilimumab, the progression-free survival, meaning how long patients did before their melanoma started to grow, was significantly better for TIL. The response rate in these patients, so shrinkage of tumor or tumor going completely away, was actually as high as 49%. Why is that different from that 31%? Well, probably one of the biggest reasons was that these patients only had one treatment before them. Versus that C14401 trial, the lifileucel trial, many of those patients, including some of my own, were on third, fourth, fifth, sixth, seventh, 10th line of treatment because it took that long to get onto the trial. And so one of the things that we've learned from these data is how important it is for us to take our patients, recognize that progression early, and get them right to TILs when it's appropriate, right? And again, not appropriate for everyone, but not waiting and trying 5 or 6 different things before we go to this treatment, because this treatment needs to be done when patients are well and healthy and fit, and optimally right after progression on a first-line treatment. And one of the things that came out of this study was data from Dr. Hannon and his colleagues that really looked at, they did something really smart. They said, yep, it's going to be a really tough 2 to 4 or 6 weeks of this treatment. But what do patients look like 6 months later, right? Have they recovered? Do they feel well? And they looked at health-related quality of life and various metrics, global quality of life, physical functioning, emotional functioning, fatigue, pain, all kinds of other health-related quality of life, and showed that these patients who got TILs actually did better than patients 6 months out, than patients who had gotten a different type of immunotherapy after progressing on a frontline immunotherapy, our first immunotherapy treatment. And again, what that tells me is, yep, we might be in for a tough month together, but once we get through that, right, the future is really quite bright for these patients. So all of that being said, this finally came to fruition. This treatment started to be developed in the late 1980s at the National Cancer Institute. It took 40 years for us to get this to our clinics, but it is here. February 16th, this was approved by the FDA. And we had the privilege and the honor of treating the first patient in the world after this drug was approved. So this approval came February 16th. That was a Friday afternoon. Many of our doctors were actually on tumor board with me when this approval came. I said, sorry, gotta go, we gotta arrange this. And less than 12 business hours later, Dr. Karani had the first patient in the world in the operating room. That middle picture was our team taking out that first tumor. And that far picture on the right was us on April 4th infusing the first patient in the world with lifileucel. So who is this right for? So right now, and we're hoping this is going to continue to evolve and expand, but right now, right, this is for patients with non-uveal melanoma. And Dr. Shrustari is going to talk about uveal melanoma and some work even with TILs that he and I have done, but predominantly he has done with TILs for uveal melanoma. But patients with cutaneous melanoma, acral, mucosal, and melanoma of unknown primary are all considered eligible for TILs. Patients who've had their tumor grow despite treatment with at least one immunotherapy regimen that contained a PD-1 medicine, so that's Opdivo, or Keytruda, nivolumab, or pembrolizumab. And if a patient has a BRAF mutation, at this point still need to have had targeted therapy medicine as well. Patients with relatively slow growing disease. So these cells, they have to grow, and it takes about 5 weeks for them to do. So if a patient has really rapidly growing disease, this might not be the right treatment because that 5 weeks is actually a really long time to wait after the surgery to go on to a next treatment. Though we can give some what we call bridging treatments during that time, really rapidly progressive diseases, this is probably not the right next step. You have to actually have enough tumor for us to take out to make these cells, and then another site of disease to trigger the cells to actually work. Good performance status. So what do I mean by that? Patients who are able to, do a full walk around the block, right? Go to work, although you don't necessarily have to be working, but would have the capability to do that. Self-care, light housework, right? This is a tough treatment, as I said, and you need to really be able to be fit enough to withstand it safely. Normal or near normal heart, kidney, lung, and liver function, because all of these medicines can affect all of those organ systems. We need to make sure that you're well enough to withstand that. As of right now, this treatment is not appropriate for patients who have melanoma that is actively growing in the brain. We're going to talk about this in just a second, but we are studying how to make this safer for patients who have melanoma that is growing in the brain. Prior treated stable brain metastasis, totally fine, totally appropriate, and those patients were included in this clinical trial. But active melanoma growing in the brain, not quite ready for prime time yet. Not on steroids, because steroids actually inactivate the TILs. And so we can be on replacement steroids for our patients who have had side effects of immunotherapy that resulted in adrenal glands or the pituitary gland not working. So low doses of hydrocortisone are okay, but high doses of steroids to treat side effects of immunotherapy, et cetera, would counteract the TILs. And so right now that isn't something that we can do. And then no active infections because of the need for the chemotherapy. So how do patients get access to this? I'm asked this frequently. And certainly we have the privilege here of being what is called an authorized treatment center. We are the only authorized treatment center in Northern California, and one of the very few in the Pacific Northwest. But there are others out there for anyone live streaming online from sites all over. There is a map of where you could find an authorized treatment center closer to home. Up-to-date testing, which we can do when you come to our clinic. And so what I wanted to tackle with just the last couple of minutes is, where are we going with this, right? So, you know, we ask questions all the time, like, great, we've made this huge progress, we just got this drug approved. None of us are resting on our laurels saying that 31% response rate is good enough, right? Where are we going now? Now we have a drug, how do we make it better, right? And these trials were actually already in the work before we even had the approved drug. So the first is this question, you know, up to 70% of our patients with advanced melanoma will develop disease in the brain itself. So we need to find a way to let cell therapy help these patients. And so this is a trial that I helped to develop when I was at Memorial Sloan Kettering, that was taken over by Dr. Shushari, and that he and I have co-managed together for now the last 2 years. And this does bring lifileucel to patients with active brain metastases. This is a very small trial where we were just trying to make sure we could find a safe way to do this. So not to study the efficacy yet, but just try to find a regimen that was safe. And this required us to lower the dose of the chemotherapy to try to prevent bleeding. It involved using prevention of seizure medicines, because that IL-2 can increase the risk of seizures, particularly for patients who have disease in the brain. And this trial was 10 patients. We're delighted to announce that all 10 patients are now through the trial. And I'm actually going to be presenting the results of this trial in a month or so at the Society for Melanoma Research Congress. But equally beneficial from this is that each of those patients offered us tissue and blood that we are bringing back to my lab to study, to understand why this may or may not be working for particular patients and how we can make it better. We're also looking forward to, hopefully in the coming year or so, an expansion of this trial to start to study the efficacy of this treatment for patients with brain metastasis. Now that we have...
Hey, I'm starting to share screen. Okay. Okay. All right.
Okay. You want me to use that? Okay. There we go. Okay. All right. So I'm going to try to get us back here, but first and foremost, to anyone who was watching online, thank you for hanging with us. We had a medical emergency in the room. Person will be okay, but thanks to all of you in the room and all of the medical team in the room. But we'll try to pick back up with, thankfully, just so everyone knows, patient and their family's blessing to continue today. So, okay. So we were just talking about completing this trial for patients with active brain metastasis, and the hope that we will have data for the first 10 patients presented at the end of October. And then hopefully an expansion of this trial to begin to look at efficacy in the brain in the foreseeable future. And that is something, a trial that we will bring here to Stanford as well as at Memorial Sloan Kettering. 2 additional trials that I'd like to mention. Again, I think on this theme of what we have, we're so thrilled that we now have a cellular therapy option for our patients, and we still know that we have a very long ways to go. And so the first is this trial of LYL845, which is a new modification on pill. And the big difference here is essentially that we just grow the cells in something different. And the idea of that is that the cells, when grown in this, may be different or potentially better media could be more have more killing ability and also more ability to trigger a long-term durable response, what we call a memory T-cell response. And so we are excited about this trial. We are open and accruing patients here at Stanford on this trial and actively treating patients here. And with the goal in the foreseeable future, actually, that this, once it passes the initial safety phase of this trial, is going to actually expand to include patients with both lung cancer and colon cancer. So as we've seen with the approval of checkpoint inhibitors, right, they were approved first in melanoma. We saw ipilimumab, followed then by the PD-1 drugs, nivolumab and pembrolizumab. They were approved in melanoma, and then all of our colleagues across many, many cancer disciplines started using these medicines to great effect. That is the hope for TILs, right? We approved it first in melanoma, and the hope is that we can begin to expand this to many other types of cancer. The second trial that I'd like to mention, which we are also open and accruing for here at Stanford, that I have led, been part of the leadership team of nationally, is this trial of OBX-115. And this is a really fancy diagram, but essentially what this diagram says is when we do that surgery and we take the cells out of a patient, we have engineered on the ability for cells to make a molecule that's like IL-2. And the cells make that molecule is called IL-15, and we can turn it on and off. This sounds like next generation sci-fi stuff. Even when we were first talking about it, it felt like next generation sci-fi stuff to me. But we actually have the ability to turn these cells on and off when we give the patient a drug. And this potentially eliminates the need for us to give that medicine called IL-2 to patients. This could make this much, much safer, accessible to more patients, older patients, patients whose lungs or hearts are not as well, as perfectly, as perfect in perfect condition. And so we are really excited about this trial. We have patients active and accruing and being treated on this trial as well at Stanford. And one of the other advantages to this trial is it is actually using a lower dose of chemotherapy in the preparative regimen. This trial is actually now nationally accruing patients with lung cancer as well as here at Stanford as well. So again, this idea that what we start in melanoma really begins to affect many other cancers in a very, very positive way. So with that, I will wrap up and conclusion. So TIL therapy is finally here for advanced melanoma after 35 or 40 years of working very hard to bring it to patients. This offers a one-time treatment option for patients. While the side effects are significant during those several weeks of treatment, they are short-lived. We are getting much, much better at managing them as we treat more and more patients and actually are helping to prevent more of these side effects now that we know what they are and when they occur. And the data from Dr. Hannon's trial really tells us that the long-term quality of life for patients who get this treatment is excellent. And lifileucel and TIL cell therapy clinical trial options are available in melanoma and now beyond melanoma. And really encourage people to, discuss this with their team if patients do have advanced melanoma. So I'll say some really important thank yous, first and foremost, to our patients and their caregivers and their loved ones that make all of this work not only possible, but worth it for us as well. It truly brings us so much joy to see so many of you in the room and online. To our fabulous melanoma dream team, that you have heard from today, to our larger melanoma dream team, our nurse coordinators who are holding it down in the back, our research team, my research lab that is working on how to understand these TILs and how to make them better. The team at Memorial Sloan Kettering, which includes Dr. Shushari and his colleagues, where I first worked on this treatment and are now actively, they have continued this with great success. My mentors who moved from Memorial Sloan Kettering to Cornell, and all of the funding agencies for all of the research that I do in this area. And that I will say thanks.
Sam is going to come up and talk about patient resources for within Melanoma. So before I go into my presentation, I want to remind people that we're going to have a panel afterwards answering questions. So we want to encourage you, if you're here in the room, to write them down. We will collect them. If you are online, please put them in the comment section. And also, we have a survey that will be going out afterwards. So, of course, can you help me switch these? And also, we on our AIM YouTube live channel, we will have this presentation available almost immediately afterwards, and we will also be sending out the recorded presentations later. Before I talk specifically about our resources, I want to tell you a little bit about the foundation and where I'm at least coming from. So the foundation was the brainstorm actually of my mother in honor of my sister Charlie, who in 2003 passed away from melanoma. So when Allison talked about what it was like 25 years ago, I can attest to you that some of the things that we have heard about, all the things we've heard about today, including the TIL therapy being available commercially, is something that we only dreamed of when my sister was diagnosed. And so in her honor and to support all of you, this foundation was born. So I will talk to you a little bit about first I'll talk about what we're doing to research. So we have our walk that's coming up in a couple of weeks in San Francisco. So we've heard a little bit about research that is being done. We focus on a fresh frozen primary tissue bank. We are collecting tissue. The foundation owns the tissue and the corresponding data, and we will be opening it up hopefully next year for researchers. So our walk and all of our walks help to go support that tissue bank. And of course, we welcome all of you to come out, even if it's just to support other people. Please join us in a couple of weeks. If you're joining us from other cities, we will hopefully have walks near you that you can help participate in. So let's talk about what we're doing as far as patients and educational resources to support you during this journey. We have a lot of resources. This is just some of them. It's a little hard. We've got several hundred pages. But our support tools, we have them in stage 2, 3, and 4. So at the time of diagnosis, it can help you determine what your options are and different things to consider when choosing which path to go along. We have Melissa Wilson, who is our Ask an Expert. She is a melanoma lead in an oncology clinic. And so we encourage you to reach out to her at any point, even your friends, family, the general public, to ask general questions about the disease. And she's more than happy to help answer you, and so that she can then redirect you back to your healthcare provider. Our Living Well with Melanoma webinar library, lots of discussions about various aspects of the medical field about melanoma. We have a clinical trials matching service that we encourage people from the day one to consider, or at least learn more about a clinical trial. There's lots out there. We can, of course, Melissa can help you give you some direction. We also want to address the psychosocial aspects of the disease. And so we have a monthly podcast called Beyond the Clinic, Living Well with Melanoma. So we have lots of different topics that we talk about. Of course, there's always lots of volunteer opportunities. The one in particular that I want to mention, though, is our peer-to-peer support program, where we try to match veterans with people who are newly diagnosed or caregivers with other caregivers. And then, of course, there's always the up-to-date research findings and more. So we have a huge oncology congress that is coming up. I guess it's this month. And so as breaking news comes out of that meeting, we will be sharing that with you. We also have discussions about FDA-approved drugs. And we have other symposiums that people can join virtually. Oops, wrong way. So, I know this topic is called AIM at Melanoma Patient Resources, but we actually are a non-melanoma as well. We started this
couple of years ago, there's a lot of individuals who are also at high risk for non-melanomas. And although there's some wonderful resources on prevention and early detection, there was really nothing or very little about the diagnosis, treatment, and follow-up for this particular population. So this falls under some of the things that we are doing with aim at skin cancer. Of course, prevention is always key. We focus primarily on basal cell carcinoma and cutaneous squamous cell carcinoma. So lots of information about that. Again, treatment options, how it's staged. We also have a number of resources. We have a Ask a Skin Cancer nurse. She works also at a major cancer center. We have webinars, virtual symposiums throughout the year, similar to the one that we're doing this morning, and survivor stories and a lot more. We have a skin cancer image data bank, which also, I'm going to jump down to number 7, includes for people of skin of color. We have an entire section which includes images for this particular population. We also try to address clinical trials. There's not a lot of treatment options in this particular population, so we of course always are encouraging people to consider a clinical trial. And then skin cancer related stories in the news, including up-to-date articles, research findings. So that is where some of the things that we are doing. And again, I always want to encourage people to reach out to us. I'm the president of the organization. It does take me a little bit of time sometimes to get back to people, but please feel free to reach out to me. It's all of you that keep me going. It's what gets me up in the morning, despite all of the aggravation and difficulties of a working day. But the fact that I know that, what happened to my sister and my family is not happening to all of you, that you have the support and resources that you need, certainly makes it worth going. And of course, my colleagues, and Garth Taylor in particular, who runs a lot of these patient and caregiver resources, please feel free to reach out to us so that we can do more to help you and your families. Thank you.
All right, it is my, to quote both of our mentors, it is both my pleasure and my privilege to introduce my friend and colleague, Dr. Alex Shushtari, from Memorial Sloan Kettering. He is an associate attending physician, and really a pioneer and a leader in the field of non-skin exposed, non-sun related melanomas. And has done really incredible work in the areas of mucosal and uveal melanoma. And he'll describe some of those journeys today, including some of the approved drugs that we have as a direct result of his work. So without further ado, Alex.
Thank you. Thanks for hanging with us, and thanks for having me. It's really beautiful here. I kind of forgot what it's like to have sunshine in my life. Living in Manhattan, if there is sunshine, allegedly, it's usually blocked by a series of skyscrapers. So I can see why everyone's happy here. I don't have to pay rent here, though, or property tax. So maybe that's the hidden side. So I'm always a fan of telling you what I'm about to tell you, and then telling you, and then telling you what I told you, is sort of the way I've been taught to give talks. So I want to first sort of define this subgroup of melanomas, and why I think they're important for us as physicians, and for those of you in the audience or later online, who need more resources and help. Maybe you have this type of melanoma, or your loved one does. I think it is important to know what we are working on. And I will talk mostly about mucosal, although the acromelanomas on the palms and soles, which we've heard about from our dermatology colleagues, are actually, those two tend to be a little bit more similar, and I'll try to explain why I think that. In those types of melanomas, we're trying to improve on the backbone of PD-1-based therapy. In melanomas that start in the back of the eye, I think many of us physicians believe that PD-1 based therapy is okay, but it's so lackluster for the average person that we are looking completely elsewhere to try to improve on treatment. So with that, I will mention that there are some companies that have supported my work or paid me for my opinions, which is always a lovely place to be. I think most importantly, Bristol Myers Squibb that makes nivolumab, ipilimumab, Immunocore that makes the uveal melanoma drug I'm about to talk about. And then, things like Iovance that Dr. Batoff-Warner talked about has supported our work for TIL therapy. I think you'll find that I'm pretty open about the pros and cons of these treatments. So I don't think this influences the opinions you're about to hear spew forward from my mouth. I'm a big fan of thank yous up front because I don't want to run too long and then speed past those. So my institution's been great to me here at Stanford. Really, Dr. Batoff-Warner for asking me months ago to come, and right away my answer was, of course. And for Sam Gilden and AIM at Melanoma has always been a wonderful force for good. There are a lot of other folks involved with this here. I want to thank the patients who and their loved ones who have sort of helped volunteer their time, their bodies, they put their trust in us, and you'll see what I'm talking about in a second. So you've heard that we've made progress. It's mostly been in cutaneous melanomas. I think one thing that we're excited about, and it's true, you can't see the pointer, right? Okay, so what we're most excited about is that plateau that folks have been talking about this morning, that once you make it to about 3 to 4 years with metastatic cutaneous melanoma, there's a pretty good chance that you'll do well, and different combinations of immunotherapies have made some progress. So here's another one we haven't talked much about. It doesn't really matter for the purpose of this talk, but it's, adding a different sort of, cutting a different break in that car compared to ipilimumab. It's called relatlimab, and that seems to have improved things as well. So we're making progress. In the United States, there's a reason we focus on skin melanoma, because if you are to get melanoma, you are more than likely to get stuff that started in the skin, or the unknown primary, which molecularly looks very much like a melanoma that was in the skin. You never knew you had it. It went away, and then creepily, years later, can just come back and say, wow, I have a lymph node with melanoma. I've never had melanoma before. But it turns out those are probably the same thing, just caught at different times. And so in the US or in Western Europe or Australia, which is, as I like to call it, Western Europe with with a convict record ancestrally, those are all sort of dominated by sun-exposed skin melanomas. And we talk about these so-called rare melanomas in this group. And they arise in things like the back of the eye, the inside linings, hairless surfaces of the body that I list there, and then the palms and soles or under the nails that our dermatology colleagues talked about earlier. I don't like using the term rare melanomas because I realized that it's actually a fairly sort of Eurocentric view of the world, and it's one of those things that I'm trying to consciously correct in myself. In China, where some of the best data for this comes out, melanoma is less common in general, but if you are to get melanoma, you're much less likely to get melanoma arising on the hair-bearing surfaces, sun-exposed surfaces of the skin. Although it still happens, you have a much larger chance of being diagnosed with what we would consider rare, for them just being, okay, it's melanoma. It can arise in any of these places. So I think that's a really important mindset to have as a clinician. And for you guys here in California, you certainly have probably on average way more East Asian ancestry folks than we do. Although New York City, we have a little bit of everything. So we carry that forward when we look at the needs that we have in our clinical population. And so here I'll just show you pictorially that these things are molecularly different. So Dr. Fontaine has done a great job talking about what you inherited. This is not what you inherit. This is just what we find when we look at the tumors. It probably, as she mentioned, 6 out of 7 times, all of this stuff comes after you're born from just, living life, wear and tear on the body. So what I'm showing here is a number of different things, but just pay attention to the general pattern. Each person with a skin melanoma is on the vertical axis, and their tumors, if they're just simple misspelling, are green. If they are truncated DNA sequences, they're black. And then if things like copy paste errors are present, they are red or blue. And you'll say, what blue? There isn't very much blue here. And I'll show you that in a second. So in skin melanoma, there's a lot of, DNA mistakes that are spelling errors in green. On the top line there's a lot of sort of skyscraper looking things. That's the mutational burden, how many DNA mistakes there are in that tumor. And you'll see that in the group that has a lot of the black bars on a gene called NF1 in the third line, those tend to have really high mutational burdens. The skyscraper buildings are tall in that top line. And so there's this broad sort of mix of things. And that's what most people think of when they think of melanoma genetics. But you can get things like in the choroid, which is the back of the eye, you can have a melanoma that arises there. And we know that it's very unlikely that sun shined into the back of your eye for that long to get you a bunch of DNA mistakes. And sure enough, when you look at a smaller group of tumors here, you don't have to be a genetic expert like Dr. Fontaine to know that this is a different type of cancer. So these have a different driver. Those genes at the bottom that were not there in the skin or hardly ever in the skin are present in uveal melanoma, and they don't have a lot of mutations except for one person in this that has that high-rise building of a mutational burden. That's probably an inherited case, which is unusual but not unheard of, as Dr. Fontaine had mentioned. So totally different. In the inside linings of the body, same sort of thing, although you get a little bit more of a spread. If you look at the mutational burden, you see some higher but mostly lower levels of DNA mistakes. You see some green and spelling errors, some black bars that are truncations, but you see a lot of these reds and blues, and those are the copy-paste error, large deletions, or large sort of multiply amplified genes. And acral melanomas, kind of, trust me on this, look a little bit more similar to the mucosals, where some of them have a higher mutational burden, but many of them don't. So these are genetically distinct. If really all else you got from that is, the colors look different, then perfect. You're with me. We've made progress. We just haven't made as much progress as we've made. And as I was sitting here listening to all these talks, I had I'm a relatively pessimistic person in my own life. I was like, we're getting more and more depressing as the day goes on. So we started off with, how do we prevent this from ever happening? To now me being like, we didn't do so good. We work hard to do better. So I'm sorry that we're ending on the place where we probably need the most work. But I hope to convince you that we really are working hard and right at the cusp, I think, of making some big improvements. So how do you treat somebody who needs your help, but their melanoma doesn't have maybe all the DNA mistakes? Their melanoma doesn't have that track record of being really well studied in these large data sets. And this is somebody's, liver in this case that has a lot of these grayish, dark tumor spots that's actively threatening someone's life in the weeks and months to come. And so we know that the immunotherapies that have led to cures can still cure people with mucosal melanoma, but just not quite as often. And so in this in this plot, I'm asking you just to eyeball the red line on the left in mucosals versus the red line in skin melanomas, the green line versus the green line, et cetera. And you can see for people with mucosal melanomas, it's just a little bit worse compared to the average person with melanoma. Doesn't mean it can't work, it just doesn't work as often. And then we did this analysis. It was led mostly by our colleagues in Australia and Europe, and that sort of said, all right, how often did you use one of the immunotherapy drugs? How often did you use the addition of ipilimumab? Where if I go back one to remind you, in skin melanomas, the red is a little bit better than the green. And we've always kind of thought that based on an early analysis of the two drugs in mucosal. We always thought initially it's better to use more. More is better. This is an aggressive disease. But unfortunately, it doesn't really seem like in the real world, when we looked at about 500 cases, that even our best treatment is doing all that great, to be honest. And, I think we need to do better. So our colleagues in China, where, as I mentioned, have a more broad spread of the types of melanomas that arise in folks in their backyard, they have the ability to run. It's actually, I'm jealous of these folks. They have a very, I think, centralized process to sort of just, hey, I have an idea. Let's go ahead and run that trial, and we'll run it in Beijing, and they get a bunch of people to participate in that trial, and they do them relatively quickly, at least much more quickly than the story I'm about to tell you later in this talk. So in the last 10 or 15 years, most of the important work from mucosal melanoma has actually come from East Asia. And Dr. Jun Guo, who I'm pretty sure I unfortunately butchered the pronunciation of his name every time I say it, but Dr. Guo has been just, I think the leading researcher for mucosal melanoma in general, because he puts forth interesting sort of ideas. And in this study, it was using that backbone of PD-1 blockade that you've heard about, and adding a pill that blocks new blood vessel formation. And this pill is not invented for melanoma. It's been FDA approved for things like kidney cancer. This combination recently was approved for kidney cancer, endometrial cancer. There are some other cancers where it's showing activity. They said, listen, let's try it in our patients with mucosal melanoma. And as Dr. Betoff-Warner mentioned, you want to see the bars under the horizon here, a so-called waterfall plot with a nice big splash is a good news kind of study. So this type of shrinkage rate was pretty darn good for this type of melanoma. But one of the limitations for us in the United States is that each and every single one of these patients is, in this case, is of Chinese ancestry and treated in China. This was a single center trial. When we looked at this same process of using a PD-1 blocker, in this case, pembrolizumab, plus a different blood vessel blocking pill called lenvatinib in this case, they did see in cutaneous melanomas, mostly in Europe, mostly in the United States, they did see some benefit here. And there was initially, some interest, and maybe this one-size-fits-all approach, maybe this is something that we can use in general. Unfortunately, I think I took that slide out, actually. Unfortunately, it was a negative trial when they actually tried it in a randomized fashion, which is the highest bar to sort of prove something. So for skin melanomas, for things in the United States, there isn't like an FDA-approved PD-1 and blood vessel blocking combination. But again, back to China, they said, you know what? Why don't we try that same approach? Add a chemo pill. Why? I don't know. They just decided, and they tried it in acromelanomas. And guess what? That waterfall looks very powerful. There's a lot of splashes under the water there, where about 60% of people in this initial treatment trial for acromelanoma have a significant shrinkage of their disease. It's pretty darn good. So again, we're getting our signals from our colleagues in East Asia that maybe not for all comers, maybe not for all skin melanomas, but for these less common, quote unquote, or non-sun exposed, which is the way I like to think of them, these non-sun exposed melanomas may be uniquely sensitive to this combination. And so the questions that I had in my mind, this was the early part of COVID, we were all sitting at home freaking out, and saying, like, what can we work on to sort of, feel useful in my job and in my life. So we started applying for grants, and Dr. Betoff Warner did, and I did, and all of us were doing this, right? And I was lucky enough to sort of say, why don't we try the same East Asian approach and just try it in a US based population, and was able to get funding from the NCCN and the company Pfizer to study, this is a busy slide, but study what I called the 2 shots on goal study for our patients with mucosal. And just like the Chinese study, we wanted to use a PD-1 blocking drug because that's the backbone that helps some people anyway. And then the blood vessel blocking pill axitinib. And it's a small study, it's only 20 patients. And we basically said the first part of the study, we're trying to just recreate the effectiveness that they saw in the Chinese study, make sure it's not a fluke. And then the second part of the trial is, if it doesn't work, could we add radiation or the drug ipilimumab as a triplet? So I thought it was a nice idea. Obviously, I was trying to get funding for it, but in reality, it has been a nice, I think, option for people to say, you get 2 chances for a novel treatment for your mucosal melanoma. And so I'm not technically allowed to really give you full data updates on this study, where they're still sort of maturing. But I wanted to show you we've successfully enrolled all 20 patients just recently. So we're waiting on, some data to mature. But we're seeing sort of 3 broad patterns. And here are these are the real scans that we sign off on for official measurements. And here you're not gonna be able to see very much. There's a red line. This is actually an MRI of the person's rectal tumor. So the sort of, looks like, I guess, eyebrows and eyes on the left side, but that's the sort of front of the rectum, the back of the rectum. And they're outlining a tumor that was actually quite painful for this patient. It's about 1.5 inches by 1 inch right in the rectal canal. And quite quickly, we saw shrinkage that's continued. This shows us a year of benefit. The person's now close to 2 years of benefit. And I look at this pattern and say, we can't technically say it was from the pill. You can't technically say it's from immunotherapy. It's definitely from one or the other, but probably both. The second pattern is something that we in medical oncology are more used to from a pill or targeted or chemo-based approach, which is it can work for a little while, but then it stops working. And we did have, a couple of folks unfortunately get, in this case, a sinus tumor pushing on someone's eye that shrunk really nicely, stage shrunk for a short amount of time, but then grew again. And I sort of think of that pattern as maybe the pill was working, maybe not so much the immune system, because as we've shown with, Dr. Betoff Warner showed with pill, usually, not always, but usually if the immune system is on the hunt successfully, it can hunt these things down and keep them under control for a while. It's much more common for like a man-made molecule that you just say, swallow that pill, that the tumors will outsmart that one man-made molecule. So I look at this pattern and say, well, maybe this is a pill-based benefit, but we got to do a little bit better. And then, of course, there are folks that have not benefited from either approach because we see rapid growth on the first scan. So we are trying to use this as a stepping stone to say, can we prove that you can't just say, I have melanoma, so go get some immunotherapy. It's all the same. Go get it, the same treatment that, someone with skin melanoma has, you should get. Melanoma's melanoma. I think we're really trying to get more precise with our definitions and do better. I would love to put these head to head. And this is actually the middle part of the talk, is actually talking about, as a clinical researcher, let me share with the patient community a little bit about what makes our job really exciting and awesome and amazing, but also a bit challenging and frustrating. And if we want to talk about it in another setting, I can use some more colorful language at various points. You can just imagine it in your brain as we go through. So what are the major considerations? We have potentially a couple different trials now showing benefit, and say, well, why don't we prove that it's better than the existing process? And the question is, well, who's going to pay for it? And for mucosal melanoma in the US or Europe, it still has this idea that it's too rare to really be worth a company's time and effort and money. Logistically, if a company's not interested, there are cooperative groups. So Stanford, with SWOG, for example, there's academic, alliances that are federally funded that help us do these kinds of things. We may have to use a slightly different pill. That's a bit different, but could we, convince that person? And then, will patients with advocacy groups, will their doctors be okay with saying, I'm going to refer someone elsewhere for a clinical trial? That's something that we have to discuss through. So it's not so straightforward. I'm stuck on number one right now, trying to find somebody who'd be willing to fund this kind of thing. But I should have put a trigger warning on that. I'm sorry that the next big question for us is, how do you treat someone who has a tumor just in one spot, where Dr. Claney just said, hey, we can go in and do adjuvant surgery, for example. I love that idea. We love Dr. Coit's comment about adjuvant surgery. Can we use something that can reduce the chances of this so-called localized tumor that is still very, very threatening to somebody's well-being? How do we improve on that? And I'll jump past this just in the interest of time. There isn't a lot of data for using the backbone of immunotherapy, PD-1 blockade, as prevention in mucosal melanoma. So we tried to go after this big unanswered question. How many people are actually cured in the modern era without medication? Turns out that number is a little bit harder to find than you think. Can you actually predict how many people with modern immunotherapy are still not going to do well? Turns out that is actually difficult to answer in the clinic, because we don't have a lot of great modern prospective data. And then how do you actually, best prevent this cancer from coming back? Is it PD-1 based treatment like it is for skin melanoma? Is it chemotherapy, which has shown some benefit in mucosal melanoma? Is it the PD-1 and blood vessel blocking drug that I just showed you has some benefit when you can see the tumor at the start? So this was a big unanswered question. And so this is the middle part of the talk that I call, no offense, doc, but what takes so long? When people want to know, hey, what's the best thing to do? And I sit there and I go, well, this and that. And then in the end, you see people's, they're either freaked out or they're sometimes bored and sort of saying, cut to the chase. Can't you just give me an answer? Tell me what to do. You're the doctor, right? And sometimes when you know a bit too much about something, you know what you don't know. And it turns out that it takes a long time to try to get these things together and try to even answer the question. So this has almost nothing to do with the science. I'm going to walk you through a trial that's currently open. You guys have opened it here at Stanford. Thank you so much for doing that. And it is a 7-year-long story to get it open. Okay, it doesn't mean we're going to talk about it for 7 years, but it's a very long story. So how do you develop a national trial for a so-called rare disease? June of 2015, a cooperative group called the NRG said, hey, we want to get into, melanoma, and we want to do, they're a gynecologic group originally, so they want to do vaginal melanomas. And we said, okay, here's an idea. We'll give some immunotherapy first, then we'll do surgery, and then we'll actually compare chemotherapy to nothing to PD-1 blockade. And then we lost by a vote to a single arm trial concept because that group said, oh, this one's too big. It's never gonna work. And we said, okay, fair enough. That was June. 4 months later, we changed the concept around a little bit. We had to drop the chemotherapy. The new cooperative group said, you know what? We love where your brain's at, but it's just not realistic. Let's simplify it, get rid of the chemo, makes it a smaller study. And we said, okay. And it took 7 months from when we submitted to the new to the Alliance group, who's running it now, spoiler alert, and submitting it to the federal group, which is called CTEP, the Cancer Therapeutics Evaluation Program. Now, I'm about to talk about the CTEP role. I love CTEP. They have a difficult job and they have an important job, but it's kind of like going out to dinner with two people. It's like you, your loved one, and deciding on dinner. It's so simple. And maybe not always, but hey, what do you feel like? What do I feel like? I don't know. Let's go get some Chinese food. Great. Versus CTEP is like going out to dinner with 12 people and saying, do you want to, no, we ate Chinese food last time. Okay, what about, just pub food? Oh, I hate pub food. And CTEP is like, you have to get a jury of your peers to unanimously agree on where to go to dinner. It turns out it's a very long process. And so here's what happened. We initially had some pretty good results. So it only took 8 months to get the study approved, which is actually pretty short. And then it took 4 months to get ready to launch. So it only took a year at this point. We're at Labor Day 2017. And I remember it was Labor Day 2017 because that's when the preventative PD-1 study was published in the New England Journal of Medicine. And there was a positive, what's called recurrence-free survival benefit, meaning, it worked a little bit better at delaying, the recurrences in skin melanoma. What does that have to do with our project? Very little, but they didn't really realize that. They didn't realize the difference between the good news that just came out in skin melanoma and what we were trying to do in mucosal. And the folks at CTEP, who really have an important and difficult job, got together and said, we don't like this trial all of a sudden because we know that preventative nivolumab is better than ipilimumab. And so we feel it's unethical to not give half the people in this study PD-1. Now we said, well, what about the one dose that we're giving everybody? We're giving everybody one dose. And you just heard Dr. Plenty say that we just had this amazing trial that showed that one neoadjuvant dose, one dose before surgery, was better than doing it afterwards. We had a sense, I think, those of us that were putting this trial together, we had a sense that it was a good idea. But when you're trying to go out to dinner with 12 other people, any one of those 12 people can sort of torpedo your idea for some good Chinese food. And that's unfortunately what happened here. And so am I bitter that they called it unethical? Yes. Because I like to think of myself, and I may not be the smartest or the tallest or whatever, but I try to be ethical. So I'm still very frustrated by this because when you show it to melanoma people, even today, if I polled the melanoma people, is this a cool trial? Like, would it still be relevant today? It would actually, wouldn't it? It's sad that it would be, but 7 years later, it still would be a really cool question to have asked and answered. Oh, well. So for 2 years, I literally was like, I'm never doing this ever again. One of my mentors has a saying, life's too short to do these large cooperative group trials. Said life's too short to try to convince 12 people to go to dinner with you. And I really was at a low point. But eventually, you dust yourself off, and a couple years later, we said, all right, June of 2019, let's go. We're going to put this concept together because a group from the NRG wanted to do it. And I was like, all right, well, I'm not going to totally give up. It took about a year and a half to get the concept approved. So the first time took a year. This time took a year and a half. We're out to November of 2020. Then, unfortunately, as we were getting our tools together, we had a vendor, a company that we're paying to do the PDL1 analysis, literally just stopped answering our emails and just ghosted us, which you'd never think of as something that could go wrong. But it was our integral biomarker. It was impossible to move forward. And so you can see here that it took 3 years to submit the concept to actually get it going, and a full 7 years from the original concept that was originally submitted to actually get started. So here's the trial. I think that's less important. I think the doctors that are here know about the trial. I think as a patient, if you have a loved one with mucosal melanoma, there is right now a prevention trial if they've just had surgery. We're trying not to do the one size fits all, everybody gets the same treatment. We're trying to prove that the blood vessel blocking pill might be useful as prevention. But it's just taken forever to get to this point. So this is our medium immunotherapy melanoma subtype. It works some of the time, but not good enough. And so we're trying to improve things. And my perspective is certainly not the only one, but I think I just happen to be, involved in some of the active things. So I've been talking a lot about the trials in mucosal. I guess that's why you asked me here. So now to switch gears, that part of the talk is over. We're sort of at the third bullet point, which is what happens when PD-1 blockade just isn't very good at all. And you don't try to build off a foundation that's shaky. I had a gross looking eyeball tumor here. I took it out. That's why the slide looks weird. Even Linda asked me, like, does this mean to be blue? I was like, yeah, we don't need to freak people out with an eyeball tumor. Okay. So it turns out this type of cancer is one of the very few in this country that is not influenced by how rich you are. Okay. It's one of the very few. And the reason for that is that our treatments just absolutely, I wouldn't say they don't help anybody, because they can, but they need to be a whole lot better. And it turns out all the money in the world doesn't always necessarily buy you better outcomes if the tools you have are really just this primitive. And so here I'm showing the Ipi-Nivo curves that we've shown you and we've been very excited about for skin melanoma, have been tested by our colleagues at MD Anderson and our colleagues in Spain. And these are not even really that flat. If you believe it, over time, very few people, I would say probably 1 in 8, 1 in 10 are cured instead of half, which is what skin melanoma is doing. So we need to improve on this. So there was a big sort of landmark trial that compared PD-1 immunotherapy or ipilimumab CTLA-4 immunotherapy to this newer drug, and the drug is called tebentafusp. It is a engineered sort of T cell receptor drug, and the way it works is instead of one sticky end, it has 2 sticky ends on it. One sticky end grabs a CD3 immune cell, a lymphocyte in the patient's body. The other end is where it's a very sticky end that recognizes a protein on pigmented cells, but especially uveal melanoma cells called GP1. And there's a lot of biology there. It turns out that really sticky end can only be really sticky if you engineer it for a specific language that your immune system speaks. Everybody's immune system speaks 2 languages, one from their mom, one from their dad. They picked the most common language, like English in the world is one of the most common languages spoken, but only about 40 to 50% of the world speaks English in any fashion, right? So that's what this is. It's called HLA-0201. You have to have that immune system language. You have to be born with that language for you to be, eligible for this treatment, because the drug is just built for that language and that language only. But it turns out that when you compare how long people live when they get this drug, tebentafusp versus standard immunotherapy, they live longer. none of us are celebrating and saying that we've cured the disease entirely, but this was a landmark improvement because we went from 15 years ago not having any immunotherapy to 5 to 7 years ago being excited to try the immunotherapy pembrolizumab, to realizing that it sucked for uveal melanoma, and already finding a drug that for 40% of people is better. And so that is, I think, the pace at which we're trying to move. We're trying to move the needle very, very quickly. But here's where I said all the money in the world didn't really matter for uveal melanoma. Well, it may start to matter. And why is that? It's because if you have less disease when you start, it seems like you do better on this drug. And so you ask yourself, well, who are the people that have smaller metastases with uveal melanoma? They're the ones plugged into specialists that get scans every few months. They're not being told, oh, don't worry about it. There's nothing that can be done. If it comes back, it comes back. Just go live your life. They're the ones plugged into doctors asking them to come back and forth for surveillance. There's also, this is a map of how common that language is, that HLA-O201, and orange is more common, blue is less common. And so you can see that ancestrally, this happens to be, more for people of Western European ancestry, which is okay for uveal melanoma. Uveal melanoma is most common for those people. But of course, it does impact people who are East Asian. It does impact people who are South Asian, who have Afro-Caribbean ancestry to a lesser extent. So we are sort of, accidentally leaving people behind because we've designed a drug for the most common population, but it's still not reaching everybody. And so I would argue that eye melanoma, where 5 years ago it didn't matter what your socioeconomic status was, is no longer going to be the case because the HLA-O201 is variable by ancestry. Not everybody even checks for it, I think. Big centers like Stanford and my institution do, but it's not a universal thing yet. To get the drug, you have to have sort of a part-time job of caregiver to help you through it. It's a once-a-week drug that is difficult to tolerate in the beginning. So you can't just be working a full-time job on your own with no sick leave. You have to really be able to go through this. So I think it's nice to have this advance, but we have to be cognizant as melanoma oncologists. Who are we bringing with us with the rising tide, and who are we leaving behind? So anyway, this is another slide I can switch past. I wanted to also end with some cellular therapy examples because Dr. Batoff-Warner beautifully, I knew she would do all the hard work and then I could just waltz in and say, you guys are experts. I don't have to explain it too much. So we are doing cellular therapy in non-sun exposed melanomas, as she pointed out. We have, it's a team sport. So this is us in Italy with a couple of my current colleagues. It's a small group of people passionate about doing this work, and it's exciting to work together and continue to use cellular therapy to move us forward. So my institution, like Stanford, like everybody, loves to highlight success stories. And so this was a patient originally of Dr. Batoff-Warner's, and I was able to follow Roberto through. So this is like this is online. This gentleman actually had acromelanoma. Didn't have a whole lot of disease. I wanted to show you, kind of like Dr. Batoff-Warner said, we don't want very rapidly growing tumors because it takes time to grow. So this is a small, oh, you can't see my pointer. So on the left, the yellow things are the liver tumor. It was relatively small. He had a few other tumors. I thought I would just show you that this is at 18 months and sort of ongoing, a nice complete response. So we're really crossing our fingers and toes that Roberto was cured. He's thrilled, by the way, that I talk about it. He loves it. I had a grainy marathon photo. He ran the marathon less than a year after doing TIL, and it was awesome. It's just so grainy that I was like, I'm not going to show it. It was like me and him, and he's looking sweaty and grainy, and I'm like, so just imagine that you saw that photo. Here's a clinical trial that we're running in eye melanomas, where I said we got to ditch the PD-1 backbone. It doesn't work very well. So we have a pilot study of using lifileucel in this population. So we had a young gentleman come in and had tried, the standard ipilimumab, nivolumab, had tried one other clinical trial. We had a tumor underneath the skin, and right under it, there was a bit of liver tumor that was accessible. So they actually took 2 tumors out at the same time. And at baseline, he had a painful, the picture on the left is showing a painful rib metastasis, outlining that. And then there were, legit tumors in the liver. It wasn't just one tumor that I showed you for the previous patient. This patient had multiple. And so 18 weeks in, the patient actually quickly said, boy, my rib feels better. And that was helping us feel optimistic. And even though our study radiologist said, yeah, the tumors are stable, I was noticing that, like, if you look at the grayish type of color of the tumor, it looked kind of darker, like the center was a little more dead, less dense. So I said, you know what, why don't we get a PET scan as well? Because sometimes it's not a perfect test, but sometimes the PET shows you the tumors in a different way. And interestingly, we saw a lot of dead liver tumors because they're not lighting up yellow like the bottom of the heart is here on the right side. So the rib tumor had a rim around it, which we were wondering, maybe those are immune cells metabolically active trying to kill the tumor. And on the right side in the liver, you don't see anything lighting up too much. So I was getting very excited. And then the job really humbles you and teaches you how to live your life outside of work as well, because unfortunately there were a lot of dead tumor cells, but then at month 9 there was at least one new tumor that we saw. And because, as Dr. Baytoff-Warner mentioned, it's a one and done treatment, nobody really feels comfortable saying, well, there's one new tumor, don't worry, let's just watch it. So we had to recommend additional treatment, and this is considered growth of the disease after just 9 months. But we're trying to improve on this. We're trying to work. I think we're seeing these preliminary benefits. They're just not ready for prime time yet, and we're excited to sort of learn from these tumor samples and try to improve on using cell therapy in eye melanoma as well. So my last slide, second to last slide. I hope I've convinced you a little bit that melanoma is not just one disease, and we can use things like mucosal melanoma with the blood vessel blocking paradigm, eye melanomas that have this HLA specific approach to sort of say, if I have a non-sun exposed melanoma, you should be able to ask your physician, hey, it's not a very common one. How many have you treated? Or which physicians do you know who have treated some? And do you go out to dinner with them? Do you text them? Are you friendly with them? Or is this one of those things that, you see once every, presidential administration, and you're trying to treat exactly the same as your other melanomas? So I know not everybody can be seen at Stanford or MSK, but your physician should be able to reach out to somebody at Stanford or MSK or wherever on your behalf. So with that, again, I think I ran over, I'm sorry, and I really appreciate the invitation. This is the view from the Metropolitan Museum of Art and looking out over Central Park. So thank you very, very much.
Okay, we know that we have already gone a little late. We are still going to have the panel discussion. We recognize that some of you may need to go. That's okay. It's going to be recorded. It will be available to you. But if you wish to stay, we are going to do the panel discussion. And that I know Sam has been collecting questions. We have some coming in from online, and I'm going to moderate that discussion. So we'll take it from here. Okay, and then last but not least, you haven't heard yet from Dr. Sunil Reddy, who is our longest standing cutaneous medical oncologist here at Stanford. So he's going to do our discussion as well. Yeah, go ahead. All right, fantastic. So we will start with some questions in the room. Susan's going to also be feeding me some from online, so we'll try to go back and forth so we make sure that we hit as many as we can. So the first is for Dr. Karani. So for intratumoral therapies injected into the tumor, you talked about them reporting fighting off tumors in other areas of the body. Are there results in other non-tumor cells? So does it cause like off-target toxicities, things like that?
It's a really good question. Mostly the answer is no. The side effect profile is much lower. That being said, each class of agent out works slightly differently, and so how that off-target effect happens, it can be different depending on what you're using. But for the most part, for these agents as they stand right now, the ones that are approved and in the clinic, the side effects are those similar to flu because you cause such a robust immune reaction when you inject it. If you think about the one that showed the virus, so you get a big antiviral response. So 2 days after the injection, you have fevers, chills, which can vary from person to person, but those other effects that you're describing might redose, except in the area that it was actually injected. You saw the arm that I showed, that area persists, but not others.
I'm going to turn to Dr. Swetter for 2 questions about sunscreen in the room. The first is, what are the adverse side effects of chemicals of the sunscreens on the body? Do you want them? I'm going to tell you both at the same time. You want to do it? Okay. So the other is, do sunscreens reduce vitamin D absorption?
Both fantastic questions. So 2 studies came out, unfortunately, right during the COVID pandemic that were maximal use studies for sunscreen were applied to the skin in volunteers, only about 24 in the first study, 40 in the second. People put it to 75% of their 4 times a day for 4 days. Nobody uses sunscreen. So it's a maximal use, unrealistic application of sunscreen. And what these studies showed is that the chemicals were absorbed through the skin, but not to toxic. In other words, it was enough of a level that the FDA did not negate the possibility of doing what's called non-toxicology studies, but it wasn't harmful to humans. And most things we put on our skin have some absorption, we just don't measure for it. So there was no human harm to this. We don't believe that there's any issues. Now, the other issue is that we talk about mineral or physical sunscreens, not sunscreens. Those are also chemical. So it's kind of a misnomer to think that they're certain micronized zinc oxide, titanium oxide. The chemical sunscreens work better than the mineral sunscreens in reaching that far UVA spectrum we talked about, again, particularly abroad. And we don't believe that there is any human harm to sunscreens in individuals. So there's no FDA concerns that the currently available commercial sunscreens are harmful. The studies in Europe and in Asia where the air filters are have done equivalent safety studies, and they have shown the same issues. And there's a nice article that came out recently looking at the rigor of sunscreen safety, efficacy. We have no reason to doubt the safety of currently available sunscreens worldwide. Again, hoping that we get these better filters and ours. The second question was vitamin D. So you get your vitamin D from diet, ultraviolet B light, and then supplements. So aggressive sunscreen and more importantly, sun protection, being inside umbrellas, protective clothing, hats, eyewear, etc., can reduce your vitamin D levels. There's some debate on that. So it's very easy to just supplement vitamin D3, that's the active form of vitamin D, will help most patients. And actually, a lot of pediatricians are telling adolescent students, kids have become less outdoor players and more gamers, get outside or take some vitamin D supplementation. So it's a real issue. It could be an issue to have some insufficiency from being inside or using a lot of sun protection, but just take some vitamin D supplementation rather than go outside and get your vitamin D level.
Dr. Funchi. Couple of questions about genetic testing. roll a couple of different ones into one big question. So, you know, if a person wishes to get genetic testing, they were asking about what should they be asking their PCP? Are there specific terms they should be using? What should they be asking for, and how would they go about actually bringing about that goal?
So there are multiple answers to this question. For everyone in general who's on the webcast, not necessarily local, the best place to go is a genetic counselor. So you could ask your primary care physician for a referral to a genetic counselor. You can actually find genetic counselors on nsgc.org. There's a find a genetic counselor link that's very easy that you can find someone certified to draw up the pedigree and to really know what to test. I would say I have a family history of cancer and melanoma. That's kind of the trigger word that would get you there. Of course, at Stanford, we have a specific skin cancer genetics clinic. That is myself and Dr. Sarin, who's a dermatologist, and we co-run this clinic. And we biasly think that we have some pretty up-to-date data. It would have the most up-to-date data, but I think if you don't have access or not local, then ask your PCP and go to nsgc.org.
So one of the questions coming in from online, and feel free to keep them coming, we'll send this one to Dr. Shushtari, but others can also feel free to chime in. People were asking, you know, certain cancers, there are more data for testing blood for circulating tumor DNA. And increasingly, we are getting questions about this in our clinic. You know, where do you see that fitting in for melanoma 2024?
Yeah, it's great to have these tools, and as with any advance in medicine, you know, we had a great talk about, you know, AI and melanoma detection, right? Is a good example. Anytime you get a breakthrough, there's initial exuberance, and then things kind of settle, and you realize you're left with more questions than, you know, potentially more gray zone than you initially expected. So cell-free DNA, I think, is a very useful tool. I think there are a lot of unanswered questions about which platforms are, you know, working well enough to sort of change our management. So the most frequent scenarios are people who are free of disease on scans, but would like to have a better idea as to whether they are at higher risk or lower risk for having their melanoma come back. And the second group of people is, I'm on treatment. Can we use, you know, treatment for visible disease? I know I have it, but can we sort of, you know, track along with my scans how well my disease is going? And I think the second one is a little bit easier to sort of say, maybe we use it as a tiebreaker, or maybe we, you know, get it more often because they're already on treatment. And there are, I think, more data for that. I think the first group of people who are free of disease, I personally, and I'd love to hear other people's opinions, I find it a little bit trickier to say, go get this test from one of these companies, and if it's positive, boy, now we're in a little more trouble, or if it's negative, you can totally be, you know, reassured. I find it hard to say that, so I would sort of focus a little bit more on the second.
Yeah, I'll comment on that, and then I think Dr. Fontaine does a lot of work in this as well, so we're going to turn it over to her. But I think one important thing for people to hear is that there are many times where we have patients who have visible known disease, and know that they have metastatic melanoma. We are treating them appropriately, and that test would come back negative even before treatment. So this test isn't that great yet. If this test was great, we would all be using it every single day. And so, you know, every cancer, as Dr. Shushtari showed, is genetically different, and he only showed different types of melanoma. You can imagine where we are seeing more of these tests in things like colorectal cancer, where the data actually are increasingly promising, right? The genetics are completely different. So what that test is looking for is quite different. And so while it may perform very well in colon cancer, it may not yet be ready for that type of application in melanoma. And so I think that's just an important thing for people to understand, because I know this is something that comes up in my clinic all the time, because as Dr. Shustari was saying, in that preventative setting, I do not use cell-free DNA or circulating tumor DNA testing. I just don't think we are ready to take the risk of treating patients with a known risk of side effects based on a test that is unproven and not, has not been tested in that setting. I would love for Dr. to take comments too.
I will repeat the same thing, actually. I think it's a very important point that these tests are a bit commercially available. The data are not caught up to what we can understand. What we understand are the next steps. So you can get these, and I do get them all the time. I have a background in genetics. It's very interesting. But they need to be interpreted with caution. So on the one side, as Dr. mentioned, you can have a negative test for real disease body. So you really need to understand that. On the other side, you can have no disease on the body and have things show up. These are most commonly what we call chip mutations, or sort of aging-related changes in the blood, but not everybody knows how to interpret those changes. So they are get with caution. Really want to have a doctor who feels very comfortable piecing apart things that might be negative when there's disease, and also understanding that not everything positive on it means cancer. I'm a scientist at heart. I like data. If I have a patient who is in the same spirit and we want to do this together and we want to talk about all these results with asterisks, I feel very comfortable doing that, but not everybody will. So just know if those tests are out there and you're very tempted to get one, but your physician is not comfortable interpreting it, that's going to be that could cause some problems in the future. But I think we will get there. These tests are really, it started with DNA, then it was methylated DNA. There's going to be proteomics, metabolomics, there are other things that will get added to these tests, and they will get more and more accurate. But for now, they are in progress. They are technologies in progress, and you have to understand and
Great. Thank you, Paul. A couple of questions from online, and maybe I'll tackle the answer to one of these first, because it's an area that I do a lot of research on, but open it up to any of us who treat melanoma with medicines in the room. But we got a question online about what are the data and what impacts could diet and exercise truly have on melanoma? And this is a question that comes up, I would say, at least once a clinic for me. The last time actually I did one of these AIM at melanoma patient symposiums, my entire presentation was on the effects of exercise and diet on melanoma. So this is a focus of my lab and my research as well. So diet is actually where we have clearer data right now. And just as Dr. Funchain said, this is still very much a work in progress. This is very early days for data for both diet and exercise, but there's data out. That is particularly with respect to immunotherapy. We know much less about targeted therapy. We know very little right now about stills or other things. But with respect to checkpoint inhibitors, we know that the gut bacteria, the bacteria that live normally along our GI system, actually really matter and can impact the efficacy of immunotherapy. And there are some nice data that come out of MD Anderson and others that suggests that we can actually potentially modify those bacteria that are in our gut, what we eat, and that could actually affect whether immunotherapy works well for some patients or not. And what we know right now, and again, very much a work in progress, is that high fiber diet, aiming for something like 30, although they are doing a randomized clinical trial of eating up to 50 milligrams or 50 grams of dietary fiber a day, which is challenging to do. But that high fiber diet potentially can make immunotherapy work. Now, as soon as I start talking about fiber, people say, well, can I just take a fiber? And it turns out that actually might be counterproductive. Because when you take a fiber, or any pill. It is a concentrated form of one or a few types of fiber. And what we're really looking for is a diversity of foods that support a diversity of bacteria that live in the gut. That's what actually helps your immune system recognize things as self or foreign and tells your immune system to kill something that doesn't belong. And so some of you, your faces certainly online and here in the room who've come to my clinic, certainly get to talk about eating a high fiber diet, but it truly has to be food you eat, not a fiber pill or a fiber supplement. Equally, when we talk about gut microbiome, then people ask me about probiotics. Right? Probiotics must be good if you're talking about gut bacteria. And as it turns out, probiotics, at least in the commercially available forms that we can buy in a pharmacy or off Amazon right now, also may be harmful for exactly the same reasons. They have 1 or 2 or 10 strains of bacteria, and those take over the gut because you're feeding your gut a lot of those particular types of bacteria. Versus eating a diversity of foods that support that diversity of gut bacteria that can potentially prime an immune response. And I say all of this, you hear me being, deliberately saying potentially, because I think we still have a lot to learn. There's actually a randomized clinical trial ongoing right now at MD Anderson, looking at different diets. There are multiple groups looking at different lab-engineered, widely diverse probiotic regimens. So I think over the next several years, we're going to learn a lot more about the role of diet. Exercise, in particular, is something we are learning about. Exercise has actually been shown, there's beautiful papers in JAMA and other journals, that exercise helps prevent as many as 20 to 50 different types of cancer. And if you look, and this breaks my heart because my research was on the effects of exercise on cancer, if you look at the biggest paper, which was published in JAMA many years ago now, it says that exercise increases the rate of melanoma. And that makes us all very nervous. You know what they didn't do? They didn't control for anybody that exercised outside and didn't wear sunscreen when they did that. Right? And it turns out if you do that and you control for the rates of people exercising indoors versus outdoors and controlling for sunscreen and good sun protective behavior, that goes away. Right? And exercise probably is actually quite protective from developing melanoma as well as other cancers. We have lab data from my lab and others, and actually an upcoming presentation at the Society for Melanoma Research meeting next month, actually showing that exercise may help the effects of immunotherapy as well for melanoma. So again, that is all animal mouse data, mouse models. We have yet to have randomized clinical data from patients, although there are actually several clinical trials going on. I don't know if anyone has anything you want to add to that. I'm going to go back to Dr. Shushtari and maybe Dr. Munchie. Any progress and targeted treatment for NRAS mutations?
Yeah, so NRAS mutations, for those who don't know, second most common sort of driver in skin melanomas, and they're present in acral and mucosal melanomas as well. These, I would say, are in some promising trials. I think that there are a number of compounds being tested to try to improve on the backbone of a MEK inhibitor, which was tested over a decade ago. Looks like about 1 in 6, 1 in 7 people with an NRAS mutation who get a MEK inhibitor pill will have some benefit. It may not last, and so that's sort of our baseline. That's like, not great. There are companies that have tested combinations where that number is sort of doubled, where closer to 1. We have some benefit. I think the challenge has been anytime we try to add something to the targeted therapy, side effects like skin rash and things like that, muscle aches, fatigue, nausea, vomiting, diarrhea. These things can sort of be additive, sort of the stereotypical chemo, quote unquote, side effects start to come into play. So that has been the challenge, I think, for us in the trial space for NRAS, is that we're getting a little bit better, but we're bumping up against some side effect issues. I think we're better than we were a decade ago, but plenty more needs to be done.
Just to say that when we target NRAS, we're trying to target the pathway instead of NRAS itself. And what we've learned from KRAS, which was supposed to be the undruggable target, is that we're getting better at targeting undruggable targets, and that perhaps, there will be more progress in actually targeting NRAS itself. There was a hand up front. I think Daniel, did you have a hand? He's writing notes. Did you have a hand earlier? For a question, Palo? Maybe not. Okay.
Sunil, I'm going to start with you for this and back to Alex. But one of the questions was about when we add the blood vessel targeting drugs. So in this case of VEGF, and Dr. Reddy is leading the nivo-cabozantinib trial here that Dr. Shustari talked about. There are also about additional toxicity when we add cabozantinib, what the side effects might be.
Yeah, there's always some additional toxicity, usually when you add drugs. Whether we can measure them or not is different. It's complicated. But with the blood vessel drugs, they're what we call category. That category, you get elevated blood pressure, be a common one that comment on. So just stop with that.
Anything else, Alex?
Yeah, that's definitely the most common one. I think it takes the right person and the right physician to be allied to do that combination, because skin issues arise. You can get calluses or sores on your hands and feet. You can lose your appetite on the drug or lose some weight on the drug. So if people are squeamish in my clinic about doing a trial, it's not the sort of like, oh, just do it, like you won't even notice, like no problem. That's not the type of trial it is. I think it's for motivated people who are like, hey, I want to do something more. Can I do something? I would say we can, but just so you know, you'll have to take blood pressure pills. You'll have to, your partner or your loved one will have to do the dishes with a lot of hot water. Because otherwise you'll get calluses on you. So it's been a challenge, but our kidney cancer colleagues have figured out how to do it. And if they can do it, I'm competitive. I think we can do it too.
Great. We have a couple of dermatologic directed questions on the list.
So one of the questions is, what would it take to collect 1,000 times more training data for augmented and automated systems? And that's really a really wonderful question, because we are trying to scale this so that we can train AI and validate these systems to be more useful for our decision making. One of the issues that we developed at Stanford through my colleague Roxanne Danish, who was part of the research, was to come up with true image, because image quality is a major issue. We see different areas like ruler bias, hair, lighting, zoom, camera angle that really affect the ability of the AI to accurately come up with a diagnosis or put the algorithm in a way in the convolutional that works. And so we have to have standardization of images. Beyond that, we have to have accurate labeling of images. And so we can't just scrub data and pictures from the internet. We know that that doesn't work. It's not a very good way to get accurate data in. Bias in the AI training, it means bias. That's what we have to really look at when we have large scale image data sets. For the prospective real world validation, the multimodal data set that we've developed through Stanford, which we're terming MIDAS, is really going to be a benchmark data set for training. And that's what we're doing internationally, working with other key AI groups around the world to share the labeled accurate image quality, high quality images to actually use for AI training. So that's happening, but that's something we also had to learn in 2017. You just need the best data coming. There was one other quick question on additional sunscreen or adjuncts to sunscreen, rather. Are there other supplements that can be applied or taken to repair DNA in the skin to reduce recurrence of melanoma? Well, we're not at that point. So giving a medication to prevent disease or to prevent recurrence are sort of two different things. We are looking at various safe vitamins, antioxidants, topicals, stimulators of pigment synthesis that could actually prevent melanoma. That whole field is called chemoprevention, or now more actively therapeutic prevention. We haven't yet identified the most effective candidate drug or agent that's a safe vitamin supplement over-the-counter product that we can tell patients to take to prevent new melanoma from forming. There are some very interesting data that are coming out with various antioxidants. One of them, one of them is like based on polypodium leukotomas, which can actually prevent sunburn. It can kind of reduce the time you spend or increase the time you spend in the sun before you sunburn, but it's not a sunscreen. So there are things that are happening that are going to be an adjunct what we're doing with physical sun protection. Sunscreen. Beyond that, there's a lot of excitement with what we think about the skin microbiome. Can we harness bacteria on the skin and activate them in ways that will prevent sun damage, DNA damage, and bacteriophage work is also being done at Stanford, which is sort of a harbinger of using the skin microbiome. So there's a lot we think that's going to happen with better sun protection technology down the line.
Great. I think we'll take this last question and then we are getting the acts that we need to wrap up.
Dr. Swetter, just following up on that, do you have any more to say about upcoming melanoma vaccines?
That's actually going to leave for the group. And someone did ask about our community registry of California and the multiple primary melanoma studies. So those are all tied in with our Wipeout Melanoma efforts and what we hope to do to again engage the community in our research. I'll let you answer the vaccine question.
Yeah, I'm going to do that super quickly. Right now, we are not at the stage where we have a vaccine that prevents melanoma development in the first place, right? There's been a lot of discussion in the news about in New York Times articles and CNN articles and other things about this quote unquote melanoma vaccine. And that is really a vaccine slightly different from what we think of as our viral vaccines, et cetera. Something that has been made after someone has a melanoma. When we take that out, we look for the specific markers in their melanoma and develop a vaccine to help reduce the risk of recurrence. That is still in a clinical trial. That is a phase 3 clinical trial that is now ongoing. But it's not a vaccine the way we think of, a typical vaccine. There's also an ongoing vaccine trial for the treatment of advanced melanoma that is in a much earlier stage as well. But nothing for a true prevention vaccine the way that, we think of, a viral vaccine that we're used to. With that, I am going to wrap this up. We are so grateful to all of you for joining us today, both in person and online. And we look forward to seeing you.